there is neural dysfunction that's called TIA. It's just a way for cerebral vessels and the circulation forces. The internal carotid, CA, portions of the vertebrals, PCS. And then coming to the types of stroke, we all know that is hemorrhagic stroke, where there is rupture of the blood vessel, and then ischemic stroke, where there is a thrombosis. The ischemic stroke again divided into several types: atherosclerotic, lacunar, cardiopulmonary, lipogenic, and then there are several unusual causes like Daiabetic. Stroke rehabilitation, then cognitive management, neuroprotective, several modalities are there, but I just focus on the reperfusion, that is the reperfusion or recanalization of the vessel, which is advanced therapy in the stroke. This reperfusion includes either intra-arterial thrombolysis or intravenous thrombolysis, or recently we are doing the large vessel occlusions. We are doing endovascular clot retraction or aspiration. Coming to the management of acute stroke, the endovascular management or the reperfusion therapy has become the standard of therapy. If the patient comes to the hospital within 3 hours of the onset of the stroke, and it was RTPA, reverse trans, alteplase was approved in 1996, and then it was approved up to 3 hours, and later on the window was extended up to 4.5 hours. Why the stroke, the reperfusion therapy has come into the picture is that the brain is, time is brain. We all know that. If we allow the more time after the infarction, after the thrombosis, the more the neurons are going to damage. That is, when there is a blockade of the blood vessel, there will be the damage starts in the brain. This damage, that is red area, is dead area, and then the surrounding the green area is the tissue which is going to die. This is called penumbra. If you don't recanalize, if you don't do any recanalization, and then the green areas will also die, and then there will be big red dead brain, and the damage will be permanent, and then the patient may lead to permanent paralysis or death. But if you recanalize, and then if you salvage that green tissue, that is penumbra, we can minimize you can salvage the patient from the stroke. Coming to this NIH stroke scale is the scale where we use to assess how much brain damage is. What is the ischemic parameter roughly? Because if there is no stroke, NIH is 0. If the 0 to 4, we call it is minor stroke, 5 to 15 moderate stroke, and 16 to 20 moderate to severe stroke, 21 to 42 severe stroke. Because these recanalization therapies we can use only for the moderate strokes, but minor stroke generally recanalization therapies, like especially the tissue plasma reactivator or the tenecteplase, we don't generally advise for the minor strokes because the risk of bleeding is more if you use these therapies for the minor strokes. If the NIHS is more than 6, then the patient if the patient comes within 3 hours to the hospital, or within 3 to 6 hours, more than 6 hours, the therapist differs. But if the patient comes within 3 hours, we do CT angiogram, or directly we take the patient to the cath lab and try to do angiogram, because within 3 hours, if the patient comes, these are the patients which are going to benefit from the endovascular interventions, especially. So these patients need to be thoroughly investigated. The patient comes between 3 to 6 hours. We just do the standard CT angio and MRI based on the investigator findings, whether the large vessel is occluded, small vessel occluded. We do go for whether to go for thrombolysis or to endovascular treatment. If the patient comes to more than 6 hours to the hospital within 24 hours, we still can do salvage the brain tissue if you can define the ischemic penumbra by way of advanced imaging, especially the CT perfusion scan, MRI, or angiogram, etc. Especially the perfusion scan helps in these cases where to deny the perfusion mismatch. This is just a nutshell, a slide for a nutshell of showing the different aspects of the stroke treatment, especially here you see the large vessel is occluded. If the large vessel is occluded, there is the brain is dying, but there is a dying area of the brain. But if you look at the perfusion scan, the patient can come to the hospital within 3 hours. You see the CT scan is normal, but the perfusion defect is very big. So in these settings, what we do, if the patient is in window period less than 4.5 hours, we do intravenous thrombolysis. Intravenous thrombolysis, the patient, even after intravenous thrombolysis, if the patient does not respond to the intravenous thrombolysis, and then we do go for a bridging treatment, that is endovascular treatment. After that, you go to the endovascular treatment of if the major vessel occlusion, we do some clot retraction or clot aspiration retrieval methods. If the patient is in around 6 hours, if they come to the hospital, it is unlikely that the patient benefits from the intravenous thrombolysis. And then previously we used to do intra-arterial thrombolysis also, but nowadays as the advances have come, endovascular treatments have come, there is instead of intra-arterial thrombolysis, directly better to go for endovascular treatment. If the patient comes more than 6 hours to 24 hours, we need to do define the ischemic pneumonia by advanced imaging and then try to go for the endovascular procedures. I'm just focusing on the endovascular treatments which are available in our settings, in our hospitals, especially all the corporate hospitals.
2 minutes more.
Yes, sir. So IV TPA is the one which generally we used to give, but it was standard treatment which is proved to be efficacious within 3 hours. Now its window is extended to more than 4.0 hours, but IV TPA has got limitations. The large vessel occlusions, MCA, proximal MCA, and then internal carotid artery, they don't respond to the intravenous 3PA. So what we do is we have to do something to salvage these patients with endovascular management. This has become standard of therapy in the late 90s, and then now revolutionized the treatment of strokes, especially the acute mixed with large vessel occlusions. We do use a lot of techniques, especially in large ischemic core areas, especially the MCA is, proximal MCA is thrombosed, or the internal carotid thrombus. It was proved to be very much beneficial in patients with large vessel occlusions. The SELECT study has proved it, and the benefit was very much promising. The SELECT 2 study is currently recruiting the patients to prove this. This is in posterior circulation. You see there is a basilar artery totally occluded, but later, after the clot direct aspiration, the vessel is very well seen. We have recently done a patient which was done by in our Kim Sunshine. This is case 1 where you see a 30-year-old man has come around 7 hours to the hospital, but there is ongoing ischemia. The patient was still conscious. The power was around 3. But there is a complete occlusion of the internal carotid artery on the left side. But what to do with this patient? So, though patient has come to the hospital more than 6 hours later, because the patient is conscious, the power is not that bad. There was a moderate stroke. It was not very severe. Though CT scan wise, his aspect score is more. The NIHS was around 14, 15. So we entered with a clot retrieval therapy. So this is what we see the angiogram. CAG, there is complete occlusion of the left internal carotid artery. You see the clot here. And then after the clot retraction, you see the entire clot with the shape of the internal carotid, the same shape. The clot was aspirated, directly aspirated. And this clot is retrieved here. And then there is a complete recanalization of the vessel. You can see this. So there is a complete recanalization of the vessel. This is what we can do in the tertiary care centers like us, where Kim's Sunshine we are doing. And they come to the mild strokes with proximal occlusion. There is a proximal occlusion, there is internal carotid artery occlusion, but the stroke is very mild. What to do? The NHS stroke is score is less, that is less than 5. The deficit, the weakness is very less, but the major vessel is occluded. What to do in these patients? The literature is confusing, but they say that there is no difference between the endovascular treatment and the best medical therapy. But if you continue to wait for a long time, and if you try to do it as a rescue therapy at a later when the patient is deteriorating, the patient, we may not be able to salvage the patients and there will be worse outcomes. So there are subgroup analysis happening in this set of patients, and there is benefit even after 6 hours to the minor strokes also. Yeah. Some patients are responding. We can see this is a case number 2 where a 50-year-old female has come to the hospital after 12 hours to the hospital, and there is a large vessel occlusion. You see the entire right interlocutor artery is occluded, but the infarct is very less. The very patchy, small, patchy areas of infarct. So the penumbra is very big here. By obviously we can see the penumbra. So what to do with the patient? Patient is power is around 3/5. So what to do, whether to wait or not. So the patient came after 12 hours, and then the patient was doing very well. We just continued with the antiplatelet therapy and then anticoagulation, low molecular heparin, and then see after 3 days, the vessel started opening. I just opted for conservative therapy rather than going for clot retrieval or endovascular management after the 12 beyond the 12 hours, and the patient was doing good and just opted. It's all decision of the neurologist by examination and the clinical findings. It is the neurologist to decide whether to go for endovascular treatment or to wait. And then because the interventional radiologist or cardiologist will just try to do their job by doing the clot reduction or endovascular treatment.
Dr. Gopal, please summarize.
And finally, this is what happened after 1 week. We did the CT angiogram, the complete reconstruction of this patient without any endovascular treatment. You can see this in summary. Nowadays, in the recent past 5 to 7 years, has been the tremendous progress in the endovascular treatments.
8 minutes.
The reasonable chance for patients with the moderate to severe large vessel occlusions, if you remove this clot, there is a reasonable chance to survive these patients, and the deficits can be minimized. The endovascular treatment or cataract thrombectomy is the gold standard of treatment nowadays. Its availability limited by the lack of trained neuroradiologists in some hospitals. The role of neuroradiologists and cardiologists in stroke is expanding from the diagnostic help to acute therapy in hospital where such facilities are available, like our hospital. So, thank you very much.
Yeah, thank you, Dr. Gopal. In short time, you have given a very exhaustive information. Thank you. Now, I call upon Dr. Rajeev to speak on diabetic kidney disease, state of art. As you all know, Hyderabad is a city of diabetes, and patients who don't control their diabetes with continuous HbA1c, definitely they land up with damage to the kidney. I request Dr. Raju to complete in time. You got 8 minutes. Because there are a lot of topics to be covered, and already we had started a little bit late.
Thank you, Kasturi sir, for inviting me. So I just want to put a slide regarding if we had to choose one disease, and if one of those diseases was diabetes and hemodialysis, where exactly it would sit. Unfortunately, diabetes, the combination of diabetes and hemodialysis is worse than many cancers. And this is something we see every time we go into our dialysis units. This is a very sobering slide. The treatment of diabetic kidney disease, this is by physicians in the United States, is wholly inadequate. Basic targets like BP control, HbA1c control, the use of RAS inhibitors, statins, SGLT2 inhibitors, these are all hardly 50% in many cases. Now we are used to thinking of diabetic kidney disease as proteinuria coming first and then renal dysfunction happening later. But this is not always the case. So proteinuria goes up, renal function goes down. But now we know that our diabetes patients are taking many paths towards kidney disease. So there are patients whose GFR is stable initially and then they develop proteinuria and then the GFR goes down. Or there are patients whose GFR is relatively stable because of treatment probably. And then there are people who go down very steeply in terms of their GFR. They'll come to you with creatinine of 2.4 and hardly 500 milligrams of protein in the urine. How do we explain this? Now this is a path that a typical patient might take towards dialysis. So this patient is on treatment, but he's having episodes of AKI. And there are so many events that happen like cardiorenal syndrome, NSAID use, drug use. All these things will eventually put this patient in dialysis. The GFR keeps dropping, but the creatinine is stable because there is hyperfiltration going on. So what is the new definition of diabetic kidney disease? It is persistent albuminuria or decreased GFR. Nowadays, we don't need albuminuria to diagnose diabetic kidney disease. There is long-standing diabetes retinopathy, and alternate etiologies are unlikely in these patients. This is how hyperglycemia will ultimately lead to ESRD. And what it goes through is glomerular hypertrophy, mesangial expansion, inflammation. Keep in mind that diabetes, like atherosclerosis, is an inflammatory disease. And there are risk factors for diabetic kidney disease. My boss in medicine always used to tell me the most important thing that you can do to stay healthy is choose your parents wisely. Unfortunately, we can't do that. So age, sex, and genetic factors can't be modified, but the things on the right can be modified. We are all aware of the stages of chronic kidney disease. Keep in mind that your creatinine is absolutely normal until stage 3 of CKD. So a person with 1.1 creatinine, even though he has lost 50% of kidney function, has normal creatinine. 90% of all CKD patients have normal creatinine. So how do we protect kidneys in diabetes? Keep in mind that these are the 3 main drivers of diabetic kidney disease: inflammation, hemodynamic dysregulation, and hyperglycemia. So we should be targeting these. And how do we do that? Of course, the initial step is a multifactorial risk reduction: control blood pressure, use statins, control blood sugars, and lifestyle modification. How do we deal with albuminuria? We have to understand the pathways that are responsible for albuminuria. All the protein that is coming out in the urine is not all the protein that has been filtered. A lot of it has been reabsorbed. Now, we used to think of microalbuminuria as 30 milligrams per day, but now we know that even 10 milligrams per day has clinical consequences. So these are the landmark trials in the control of DKD, and as you know, from the 1990s till the 2000s, it was pretty much barren. So the first drug that anybody thinks of in diabetic kidney disease is an ACE inhibitor or an ARB, and there are important reasons for this. The landmark trials in the 1990s established that they are at least 48% better than whatever came before. But keep in mind that what came before was 0, and these are not magic drugs. 80% of their renal benefits are because of blood pressure control. It's important to remember that there is only 1 ml GFR difference between the use of ACE inhibitor and the use of some other drug for blood pressure. So ACE inhibitors are good, but they are not that great. And now we are in the SGLT2 inhibitors era. These drugs came to us via diabetes and then from cardiologists and now to nephrologists. And there are so many trials now which show that SGLT2 inhibitors can delay the progression of kidney disease. And they do that because they act on multiple pathways. Unlike ACE inhibitors which act only on hemodynamic dysregulation, SGLT2 inhibitors target multiple pathways. At what level of GFR are you comfortable with? Nowadays, studies show that even up to 20 ml of GFR is okay. Keep in mind that it may take 1 year for the benefit from SGLT2 inhibitor to become apparent. So you need to do a lot of hand-holding in the beginning because the creatinine tends to go up. But you have to reassure the patient that this is one of the proofs that the drug is acting. And here are important studies showing that in clinically important outcomes in kidney disease, like onset of ESKD or onset of dialysis, progression of kidney disease, there is at least 40 to 50% reduction in outcomes. So this is a slide which shows you that early intervention is really important. If you intervene early, you can delay end-stage renal disease by around 15 years. However, if you intervene late, you may buy the patient 3 to 4 years. That is still significant, but not as good as intervening early. And these are all the drugs that are now available in the management of DKD, and they target all these multiple pathways. Mineralocorticoid antagonists, I'll say a word about them. So the traditional mineralocorticoid antagonists are limited by hyperkalemia and gynecomastia. Whereas we now have a non-steroidal mineralocorticoid antagonist that does not have these side effects, and this is Finrenone. You now have 2 important trials and 1 meta-analysis, Fidelity Figaro, which have shown both important cardiovascular and renal benefits. GLP-1 agonists, these are all the rage now in terms of weight loss and management of diabetes, but they also have important kidney benefits. And the way they do that is by, apart from controlling blood sugar, they also decrease oxidative stress and albuminuria. These are studies which show that there is at least 22 to 30% reduction in clinical outcomes. So the importance of preventing AKI in diabetic kidney disease progression. In a diabetic, even one episode of AKI can land them straight into stage 4 of CKD. So you have to do everything possible to prevent these episodes of AKI. And how do you do that? You have off days for ACE inhibitors and ARBs and SGLT2 inhibitors during acute illness, avoid NSAIDs, avoid nephrotoxic drugs, phosphate enemas. Don't be in a hurry to titrate BP medications, minimize contrast use, and pay careful attention to volume during elective surgeries. One word about diet. Metabolic acidosis is very common in CKD. There is a concept called eubicarbonatemic acidosis that we need to keep in mind. And what that means is that you can have acidosis even with normal serum bicarbonate levels because your bones are buffering. And this is universal from CKD2 onwards. So what does the future hold? We have expensive drugs which are very effective now, but you can't use them in everybody. So who do you target to choose these drugs? The future is actually AI, and it is already here. So we now have biomarkers with AI tools and EGFR that can predict who needs most aggressive intervention. This is one example of a clinical tool which is available online called Kidney Intel X. And this uses particular biomarkers to assess who is at greatest risk of progression of kidney disease. I'll give you an example. 40% of patients who have diabetes will never develop kidney disease because they are genetically protected. So there's no point in using these expensive medications in these patients. So you need to find out which among the patients that you're seeing will actually benefit from these drugs. Thank you.
Thank you, Dr. Rajeev, for your excellent presentation and maintaining the time. Thank you very much. So now I call upon Dr. Issac Abhilash to give its talk on evaluation and management of dyspepsia.
I would like to thank Dr. Sridhar sir for giving this opportunity to talk on this topic. Actually, when sir has asked about to select a topic, I have selected dyspepsia. In fact, dyspepsia is nothing but any discomfort in the upper abdomen is called dyspepsia. So every individual will experience it either at any one point of time in their life. So this is very common, and it's very common thing that comes to mind of any doctor. So when I was thinking about to tell about dyspepsia, it is again divided into two things, whether it could be a functional thing or a non-functional thing. Non-functional thing, there will be a disease inside. And coming to this, the most important thing that we have to consider is always refractory GERD, which I want to specifically stress about. Because as you know that most of your patients will be already taking PPI as a co-prescription for many of the medicines. All the cardiologists, neurologists and pulmonologists and nephrologists will be writing PPIs, and most of the times they even present with reflux. Symptoms like heartburn and chest pain are always there even though they are on these symptoms. So coming to the refractory GERD, the main learning objects is to understand the disease, to diagnose and to suggest the changes that has to be made in the treatment protocol. So if you consider the etiology of this, first of all to define, it is patients who are not responding to 8 weeks of PPI is defined in an optimal dose is defined as a GERD, that is refractory GERD. And the refractory response could be total no response, or it could be a partial, or it could be absent. Like there could be a changes in the symptoms or there could not be any changes in the symptoms. And mainly when there are even a mild symptoms also, we consider that as having a refractory GERD. So if you see the prevalence of refractory GERD, I mean, it is only a part of dyspepsia which I am telling. And in that, if you see that persistent GERD symptoms are seen in 45% of the patients who are already using PPIs. So this is quite prevalent when compared with any other disease. It may not cause any death, but it causes a lot of discomfort, or it causes a lot of disturbance to an individual. So reasons for failure, as you know, that the most common reason is a non-compliance. Any individual doesn't want to take a tablet, so it could result in an inadequate dosing or poor timing of dose or non-adherence to the lifestyle modification, which every individual doesn't accept. And reflex characteristics. Reflux may not be always strongly acidic. It could be even weakly acidic, which is always dangerous. Dangerous in the sense it causes more discomfort than a strong acid. And there are coexisting conditions, which are functional conditions, as I told you, non-erosive reflux disease, H. pylori, as well as obesity. And these are the causes of refractory GERD, that is PPI non-compliance, coexistence of esophageal disorders, functional esophageal disorders, and motility disorders, and delayed gastric emptying can also cause that, and residual acid, that is nocturnal acid breakthrough or a presence of acid pocket in the esophagus can cause refractory GERD. And coming to the evaluation, as you all know that heartburn and regurgitation may be accompanied by chest pain and dysphagia, but these symptoms may not reflect in non-GERD conditions without abnormal esophageal acid exposure. So whenever there is an abnormal esophageal acid exposure, there will be a pathology on endoscopy. When there is a normal esophageal acid exposure, the endoscopy appears to be normal. And coming to the non-GERD, these are the differential diagnoses for refractory GERD, like achalasia, where barium swallow or manometry helps in diagnosis; eosinophilic esophagitis, where we take a biopsy on an endoscopy and to diagnose it; and reflux-like dyspepsia, in that there will be a normal endoscopy and the pH monitoring has to be done. Gastroparesis, usually we do a scintigraphy to understand any gastroparesis. So evaluation is definitely needed. If there is a coexisting condition, we need to diagnose that and we need to address that also. So this is a small question to everyone. So investigation of choice for GERD is definitely, if a question is asked in these lines, it is 24-hour intraluminal pH monitoring, which is we commonly do. If the patient is not responding to any of the PPIs, then we really check it whether it is a reflux that is causing it or whether it is a functional problem that is causing it. And usually we advise hospitalize of the patient for 1 day, and when we do a sensor in the esophagus and we check for the pH. And there is another alternative for this, that is a capsule where we clip it in the esophagus and check for the pH, but we do need the impedance to understand the 24-hour pH. Coming to the management of refractory GERD, as you all know that it is always the non-compliance of the patient which makes them to come back to us. So we need to educate the patient about the lifestyle modifications, and we need to re-counsel them regarding the compliance, and we have to check for change for another PPI. And most of the time it is esomeprazole which has got better response when compared with the pantoprazole, rabiprazole, but especially when you are co-prescribing with a cardiac medications, rabiprazole is a superior drug because it doesn't have any interaction with the other medicines. And as you all know that lifestyle modifications, especially weight loss, smoking cessation, sleep in an inclined position and avoid sleeping in the right side, and additional lifestyle changes, especially for nighttime symptoms, you have to avoid eating at least 3 hours prior to bedtime, turn off lights when enter bed, and minimize the disturbance of the sleep. Whenever the sleep is broken or when you don't have a continuous sleep for 6 to 7 hours, definitely there is a chance of acid reflux. And treat with a PPI, and if symptoms are primarily during the night time, we can give an additional H2 receptor antagonist before bedtime, and consider a non-medical therapies. Even functional causes also has to be addressed. So these are the add-on medical therapies. One thing is a long-acting PPI. For us, dexlansoprazole is one of the things which we usually prefer, and or a double dosing of the PPI with morning and evening dosage. And in case if we suspect any of the gastroparesis, we add a prokinetic to it. Domperidone is preferred one, and there are other things like syntapride as well as etopride, and prokinetics are needed to stimulate the gastric emptying and the increase LES pressures, and reflux inhibitors. Sometimes if they are non-responding even to after addition of a prokinetic, baclofen can be used to reduce the direct inhibitor. And this is always associated with a part of anxiety, especially when it is associated with a functional dyspepsia or postprandial distress syndrome or epigastric pain syndrome or irritable bowel syndrome. In that case, we use tricyclic antidepressants as well as the selective serotonin reuptake inhibitors. So there are endoscopic treatment for that and a surgical treatment. As you know that surgically fundoplication is done, but to do that, first we need to show the evidence of hyperacidity, which 24-hour pH monitoring has to be done. Endoscopically, we do a procedure called ARMS, where we do, it is called a mucosal resection, where we do the mucosa, but nowadays we are not doing it because most of the patient develop dysphagia after that. And there is another procedure called ARMA, where we endoscopically go and do a mucosal ablation, which is very simple daycare procedure. They can come in the morning and go back in the evening. And there is another thing called GERDEX, which is similar to the fundoplication. We do it endoscopically. And all these we are doing it on a regular practice. But before doing this, we need to definitely demonstrate that there is a hyperacidity. And these are the recommendations. And so key message is persistent GERD symptoms are seen in 45% of the PPI, and those not responding to 8 weeks of PPI are defined as a refractory GERD, and patients with refractory GERD should be definitely referred for further evaluation, and patients with functional dyspepsia, overlap, volume reflux and evidence of delayed gastric emptying may benefit from addition of prokinetics. Thank you.
Thank you, Dr. Abhilash, for your lucid presentation. Now I call upon Dr. Raghunath for a very interesting topic, management of acute severe asthma. I should congratulate Dr. SridharKasturi for choosing very wide, very good topics, which will be giving a lot of information to every practitioner.
Good afternoon, everyone. I am Dr. Raghunath Reddy. I am a senior consultant and head of the department in pulmonology and sleep medicine at King's Sunshine Hospital. Yeah. I mean, this is a topic where what we have studied in MBBS, it holds good even now. There is no real drug or a new development in treatment of acute exacerbation of asthma or acute severe asthma. There have been so much of development in the prevention of exacerbations. Even biologicals are there, and newer inhalers and newer LABAs and other things have come up. But as far as the exacerbations or acute severe asthma treatment is concerned, almost it's the same what we have studied in our MBBS days. What is an exacerbation? Asthma exacerbation. Exacerbations are episodes which are characterized by increase in symptoms or decrease in lung function, where they represent a change from patient's usual status, which is sufficient to require a change in the treatment. So not all exacerbations require hospitalization. So in the guidelines, there is asthma management plan where you can even educate the patient himself how to change the treatment for his increased symptoms. So it can happen in a pre-existing diagnosed asthma case, or it can be a first presentation in a particular case. So what are the factors which increase the risk of asthma-related deaths? Any history of near-fatal asthma requiring intubation in the past, any time, it is a high risk for fatal asthma in later life also. Hospitalization in the past 1 year, and using of oral steroids now and then, and also recent use of steroids also increase the risk of asthma related death. And patients not using inhaled corticosteroids or poor adherence with the inhalers. This is the rampant problem in Indian patients. Indian patients are very, very notorious of not using inhalers regularly. They feel they have to use inhalers only when they have symptoms. If they don't have symptoms, then there's no need to use inhalers. And overuse of SABA. This is another problem in India. Now, SABA is a short-acting beta-2 agonist. Now the global guidelines are advocating to remove the SABAs from the guidelines and also from the shelves of the pharmacy. And probably in next few years, we see we don't get these Astelin and Livolin, Livosalbutamol. These inhalers will be off the shelves. Patients with a food allergy and psychiatric illness are also increase the risk of asthma-related deaths. This is a self-management plan for patients, particularly in adults and adolescents, where they can monitor their own symptoms by a questionnaire, asthma control test questionnaire, and also lung function by a peak flow meter. It is also called breathometer. You get it, na? Peak expiratory flow rate. So with that, they can monitor their functions, and then they can increase or decrease the reliever. It's not decreasing actually. They can increase the reliever or increase the controller depending upon their asthma control. And if they have increased symptoms, they can do it at home in earlier mild cases. But when the peak expiratory flow and FEV1 is less than 60% and not improving, obviously they have to contact the doctor, or they have to start oral corticosteroids. So this is the self-management of exacerbation. If the patient is using a ICS formoterol or a SABA or a ICS SABA, they have to increase the dose of the reliever as needed and increase usual maintenance dose. The MART therapy is the new concept that has evolved in the recent years, where ICS formoterol can be used as a single maintenance and reliever therapy, where the same, particularly formoterol combinations, you cannot use other combinations like salmeterol, because formoterol is a long-acting beta agonist with a rapid onset of action. So it can be used as a single SMART therapy, single maintenance and reliever therapy. If the patient is using ICS formoterol with a SABA as a reliever, you have to quadruple the dose of ICS and then increase the SABA use as and when needed. ICS with other LABA with SABA as a reliever, you have to again increasing the existing dose of ICS LABA, or add on a separate ICS to quadruple the dose. And if the symptoms are not getting better, then you have to probably use an oral corticosteroids for 5 to 7 days. So what is MART therapy? This is a new concept in the asthma management, where a single maintenance and reliever therapy, particularly low dose ICS formoterol. I mean, if you see Foracort or a Symbicort, this is the one which can be used as a reliever and also as a maintenance therapy in asthma patients, and they definitely decreases the exacerbations and the oral corticosteroid requirements. Low dose ICS formoterol reliever is preferred and superior over ICS SABA or SABA alone as reliever, and the maximum dose of formoterol is 72 micrograms. So in normal Foracort, for example, you have 6 micrograms in each puff. So you can go up to 12 puffs per day. That is the maximum dose that can be given. And how do you manage exacerbations in an emergency department? Here, first you have to assess the exacerbation to categorize into either mild or moderate or severe and life-threatening, because the treatments are very different. And you assess by history, by duration, severity, and what are the cause and symptoms of anaphylaxis and previous history medications and adherence. And you obviously you look for other vital signs, use of accessory muscles. And another thing, any patient with asthma, if they present with exacerbation, you have to look for other causes, because even if they have pneumonia or a pneumothorax, they present as asthma exacerbation. Even if they have MI or pulmonary embolism or heart failure also, they present as exacerbation of asthma. So you have to first rule out all these things, and then only, if nothing is found, you can then label it as only asthma exacerbation. And objectively, you can assess by peak expiratory flow rate and FEV1 and saturations, ABG and chest X-ray. If it is a mild to moderate case where the patient is able to talk in phrases, prefers to sit up and is not agitated, heart rate not very high, below 120, respiratory rate is not above 30, when the patient is not using any accessory muscles and saturations are above 90%, peak expiratory flow more than 50% predicted or best, then you can consider it as a mild to moderate case and use SABA, that is short-acting beta-2 agonist, 4 to 10 puffs with a spacer. You can repeat it every 20 minutes for 1 hour and look for improvement. You can even also add ipratropium if the response is not in the expected lines. Then if the patient is improving, you can even start oral corticosteroid 40 to 50 milligrams per day of prednisolone. In children, 1 to 2 milligrams per kg. And you can give a controlled oxygen to maintain saturations between 93 to 95%. If the patient is improving, then you can assess for discharge. If the patient is worsening, then you have to go for a severe asthma exacerbation protocol, and also patient to be shifted to the acute care facility. If the patient is improving, then assess for any discharge. If the saturations are more than 94, peak expiratory flow more than 60%, not needing any SABA, then arrange for discharge. You increase the reliever dose, and then add oral corticosteroids for 5 to 7 days. And then you follow up the patient. You continue using the increase in the reliever dose or the control medications depending upon the severity of exacerbation. In severe exacerbation, where the patient is able to talk only in words, is hunched up, agitated, tachycardia more than 120, respiratory rate more than 30, and saturations less than 90 with accessory muscles, and peak expiratory flow less than 50% predicted, he has to be shifted to ICU and transferred to high care facility. Here also you use SABA plus ipratropium directly, that is dual in nebulizations, and high dose ICS with a high dose ICS inhalation. Oral and IV steroid should be considered, and sometimes you can even give magnesium 2 grams over 20 minutes if the patient is not responding to the usual treatment. And controlled oxygen support is also important to maintain an oxygen level between 93 to 95%. In a life-threatening exacerbation where the patient is drowsy, confused with a silent chest, you have to shift him to ICU, and you have to consider non-invasive ventilation, and if required, intubate and mechanical ventilatory support. What are the add-on treatments you can consider?
2 minutes more, sir.
Yeah, add-on treatments is ipratropium. Aminophylline we are not using regularly, but that can be used in cases where there is less response. IV magnesium, this leukotriene receptor antagonist montelukast, and antibiotics should be considered only if the patient has lung infection. So what is the take-home message? OCS definitely helps in asthma control, but they have a lot of side effects. The need for oral corticosteroids can be reduced by optimizing inhaler therapy, and particularly adherence and technique has to be checked in every visit. GINA track 1, now the guidelines say ICS formoterol is the one which have to be used as a maintenance and reliever therapy, which decreases the exacerbations and also decreases the requirement of oral corticosteroids. Identifying and appropriate management of asthmatics at primary health care helps in reducing asthma-related morbidity and mortality. Thank you.
Thank you very much, sir, for your excellent presentation and enlightening us with the latest regimens in management of acute severe asthma. Thank you, sir.
Thank you, sir.
I thank Dr. Gopal, sir, Dr. Rajeev, Dr. Issac Abhilash, and Dr. Raghunath, sir, for your excellent presentations. Now I hand over the mic to Dr. Sashikanth.
Thank you, Dr. Thakur. We invite the next speaker, Acute MI Primary PCI, and this is by Dr. R. Rajaram. Yeah, you have 8 minutes of time.
Good afternoon, chairpersons. Good afternoon, everyone. We are going to discuss regarding the importance of the primary PTCI in the settings of acute myocardial infarction. As you know, the myocardial infarction is because of atherosclerotic plaque rupture or erosion leading to thrombus formation. Initially, there is a deposition of the platelets, followed by RBC in the fibrotic mesh, then leading to thrombus formation, which gradually increases and then completely occludes the vessel. When it completely occludes, the ischemia, initially entire area which is supplied by that vessel goes into the ischemia, and then necrotic process will start. The necrotic process always will start from the subendocardial region onwards. So you have got certain time till 3 hours this necrotic process is very, very limited to the subendocardial region, and majority of the area is in the ischemia region. So whenever you establish the blood flow, this ischemic tissue will completely recover its function. So that is our main motto. Suppose if you don't recanalize the vessel, then entire ischemic portion will go into the necrotic process, that is irreversible damage of the tissue, and followed by further complications you will face. As you know, as the ischemic time is increasing, the infarct size is also increases, that simultaneously leads to the increased mortality. So our motto is, once the vessel is closed, we have to make it normal or near normal, either with the thrombolytic therapy or primary PTCA. So what are the options between thrombolytic therapy and primary PTCA? We will see the evidence, and I am going to present few of the evidences. This is the Indian registry which was published in 2019. It has shown that thrombolysis is clinically successful in 86% of the patients. What does it mean? It reduces the pain to the patient and also decrease in the ST elevations. But is it transforming into the clinical benefits? Absolutely no. Again, this clinical benefits of the trauma, either streptokinase or tenecteplase or retiplase, whatever you use, it is widely available. You have 12 to 17% survival benefit and preserves the LV ejection fraction. But limitations are 20% of the vessels remain occluded. Even if you give thrombolytic therapy, it will not open or it will not dissolve the clot. And 45% of the patients have less than TME3 flow. That means the flow is very low in these patients, and recurrent ischemia occurs in 15 to 30% of the patients, and intracranial bleeds occur 0.5 to 1.5% of the patient. So what do you mean by TME3 flow? TME3 flow is nothing but it is a grading system of the blood flow in the blood vessel which is occluded. So once the blood flow is stopping at the occlusion, it is graded as a grade 0. If it just penetrates or crosses the occlusion site, it is grade 1. The blood is reaching to the distal part of the territory, but in a slow way, it is grade 2. It is reaching to the distal part of the vessel. Simultaneously, the flow is also normal. Then it is grade 3. So our target is to reach the TME3 flow. That means normal flow. So as you from the symptom onset, the time to the TME3 flow is which is more important than simply establishing the flow. As the time goes on, initially up to 3 hours, the mortality is, in-hospital mortality is 1.8%, but it keep on increasing till you establishes the TME3 flow. If you see the other trials like PAMI1 and PAMI2 trials, if you see, if the patient is having TME0 or 1 flow, their 6 months mortality is 22.2%, but if you achieve TME3 flow, its mortality is only 2.8%. So this is the benefit of the TME3 flow. So, and again, there is a 12-year survival rate. If you achieve TME3 flow, it is more than 75%, but if you have TME0 or 1 flow, it is only hardly 50%. So our goal is to reach the TME3 flow. So there is another entity is called the vessel patency. If you give thrombolytic therapy, the vessel patency is hardly 50 to 60%, whereas if you do primary PTCA, 90 minutes vessel patency is almost 90%. This is another benefit of the primary PTCA. And there is a decrease in the death rate. There is a decrease in the death even in the patients of cardiogenic shock also. There is decrease in the reinfarction, hemorrhagic stroke or total stroke with the primary PTCA. It is not only better to achieve the TME3 flow, it is how rapidly you are achieving the TME3 flow is also equally important. That means the time is muscle in the heart attack situations or acute myocardial infarction stage. So what we call door to balloon time. If you see the door to balloon time, that means the patient arriving into the hospital, from hospital ER to opening of the vessel completely, if it takes less than 60 minutes, their mortality is only 1%. But if it increases rapidly, suppose if it is 90 minutes, their mortality is 6.4%. So here you can observe that time is muscle for the patient. And another Swedish registry, Riksförsäkringsverket registry, which again showed that the primary PTCA is having the cumulative mortality of only 7.6%, whereas thrombolytic therapy it is 15.9%. Even in pre-hospital thrombolysis also, the mortality is very high, which is 10.3%. So how late after symptom onset does opening the infarct artery still provide the benefit? If you see here, even in the late stages also, doing or opening the vessel is much more beneficial. If you see here, if the patient is having invasive PTCA, then 8% mortality, here it is the 13% mortality. So there are, what are the limitations of the primary PTCA? In hospital or late restenosis or reocclusion may take place. Inadequate reperfusion success may occur, and then inherent logistical delays to the reperfusion, that sometimes it may take more than 2 hours also. What is the scenario in India? This is the 2017 census, almost 30 lakhs heart attacks are taking place, that is acute MIs are taking place in India. Only 12 lakhs patients are receiving the thrombolytic therapy, and only 64,000 patients are undergoing primary angioplasty. This is very, very poor, and it requires STEMI chain of survival in the form of awareness of the patients, education of the physicians, and logistical establishment of the cath labs, and then cardiologists available. So each link is critical, and if one fails, it can be harmful and fatal for the patient. Thank you.
I now request Dr. Pranay to come onto the dais and give us a talk on recent update on guideline-directed management of heart failure. Dr. Pranay, 8 minutes, please.
Very good afternoon to all. So I'll be just giving you a brief about what is the recent update of heart failure. So heart failure. So heart failure is basically classified into stage A, stage B, stage C, and stage D. So stage A is basically at risk of heart failure, stage B is pre-heart failure, stage C is symptomatic heart failure, and stage D is advanced heart failure. So we need, why do we need this guideline-directed medical therapies? To avoid the progression of the disease from one stage to another and give a good quality of life and good survival to the patient. So now heart failure again can be, the newer guidelines have told that new onset de novo heart failure is newly diagnosed heart failure without any previous history. So then the patient can have resolution of the symptoms, or patient can have persistent heart failure with ongoing symptoms, signs, and or limited functional capacity, or patient can have worsening heart failure. So heart failure can be grouped into 3 groups. It can be heart failure with reduced ejection fraction, which is EF less than 40%. Heart failure mid-range ejection fraction, which is 41 to 49%, and preserved ejection fraction when the LV function is more than 50%. And then we can reclassify over the period of time when the patient comes to us for the follow-up. If the ejection fraction was less than 40% on treatment, it has improved, then it goes into heart failure with improved ejection fraction. And how do we diagnose that? We diagnose it by first clinical history, then physical examination, ECG labs, and then we see NT-proBNP levels. We do an echo, and then we can classify the heart failure into 3 groups. And then accordingly, we initiate the treatment to the patient. So why it is important? Because heart failure is a progressive disease, and it starts from at risk, then patient who has presented to us with the clinical symptoms, and then the patient starts having worsening heart failure, and then there is a waxing waning effects, and patient lands up into the advanced heart failure state. So once these things is happening for each and every heart failure admission, there is dip in the cardiac function. At the end, the cycle of the worsening heart failure sets in, and patient lands up with mortality. So what is the characteristics of the heart failure patients in India? So the population is more younger, we have more of diabetics, and this is causing more morbidity to the patients. So usually what is the disease burden population is like 8 to 10 million, which is the largest heart failure population which we harbor, and we are younger by more than 10 years as we compare to the Western population, and CAD is the most common etiology, and also rheumatic heart disease plays an important factor, and 1 out of 5 heart failure patients who are hospitalized have rehospitalization within 1 year of the first event of the heart failure. And the 5-year mortality, 3 out of every 5 patients die with heart failure. This is the importance of the treatment of the heart failure. So what are the targeted therapies we have is RAS inhibitors, sympathetic activity blockers, SGLT2 inhibitors, and the neprilysin inhibitors. So these are the major major drugs which we have to treat heart failure, and the newer addition is the nitric oxide pathway, which is the vericiguat, which we have in the therapy. So basic management for the heart failure remains the 4 pillars of heart failure, that are ACE inhibitor, ARNIs, beta blockers, MRS, and SGLT2 inhibitors. So we start this one at a time. We don't go ahead with separate initiation. Initiate all the drugs at one moment of time, optimize them, reassess the patient, and escalate the dosages of each and every molecule as per the patient tolerance. So at risk of heart failure, like patients who are with hypertension, what is our goal is to optimize BP control. Patients who have type 2 diabetes mellitus, initiate with SGLT2 inhibitors. Patients with cardiovascular disease, we have to optimize their medical therapy, and cardiotoxic drugs, we have to do a multidisciplinary approach, recurrent screenings and monitoring of the patients, and say who are having family history needs to undergo a genetic screening. Then pre-heart failure stages, patients with LV function less than 40%, initiate them on ACE inhibitors, or who had MI can have RNE, or we have to initiate them on beta blockers. Patients who are having less than 30% ejection fraction and more than 1 year survival, more than 40 days post-MI, warrants an ICD, and if they have LBBB associated with that, then we can think of going ahead with CRTD. So the most patients what we see in our setup is the patient who comes with stage C heart failure, and then for them initial thing is decongestion with diuretics, and then 4 pillars like ARNI, ACE inhibitors, ARBs, beta blockers, MRS, SGLT2 inhibitors. And diuretics we should optimize as per the patient's volume status. And if the patient is had euvolemic, the dosage of the diuretic should be reduced to the minimal dosages so that the patient's blood pressure hemodynamics remains good. And for the after this, we reassess the patients recurrently, and then if he is improving, the ejection fraction has improved, we classify them as an improved LV function, continue with the same therapy. If he persistents to have the ejection fraction less than 40%, then we need to reassess them whether it's the African American patients, they can have an nitrates or ejection fraction less than 30% warrants an ICD, or he requires an CRTD based on the LBBB and ejection fraction less than 35%. Still the patient symptomatic goes into refractory heart failure, then for them mechanical circulatory support, cardiac transplant or palliative therapy can be initiated. So once what we initiate all these guideline directed therapies, not each and every patient will tolerate the initiated drug in the dosages. So sometimes patient might not have a good blood pressures, or still the heart rate might be more than 70. So in that case we can add ivabradine to control the heart rate. Patient still on receiving all this targeted dose, still having to have worsening heart failure, vericiguat is a treatment option to initiate vericiguat and escalate the dosages as per the hemodynamics of the patient. Digoxin, which was an older drug which was used previously for heart failure treatment, still the symptomatic, digoxin can be used. The major role of digoxin is to just reduce the heart failure hospitalization. Polyunsaturated fatty acid plays some role. It has got class 2B indication. And potassium binders, basically patients taking RAS inhibitors having hyperkalemia. So additional options are when the patient has ejection fraction less than 35% and requires a surgery, we can have a surgical revascularization which gives him better improvement in the LV function, or patient has and mitral regurgitation which is causing more trouble to the patient with heart failure, that patients can have intervention for the mitral regurgitation, can be an edge-to-edge repair or goes for a surgery. So similarly, if we have the patient with mildly reduced ejection fraction, what we require is basically diuretics to bail out the symptoms of the dyspnea. Then SGLT2 inhibitors plays an important role. ACE inhibitor, ARNI, mineralocorticoid receptor antagonist can be added to them, but the main treatment is to control the underlying disease. Similarly, with heart failure with preserved ejection fraction, we don't have a specific group of medications which were basically required to treat the patient, but diuretics to elevate the symptoms. SGLT2 inhibitors have got their new role in heart failure with preserved ejection fraction, so we can initiate that to them. And ARNI can be used basically more of hypertensive cases. We can use these things.
Dr. Pranay?
So, yeah.
I think we'll have
the last slide. Yeah. So if we don't optimize these things, what happens is the mortality goes up, and if we are delaying these things, or if we are just stopping the therapies, the risk of mortality or cardiovascular readmissions goes up. Thank you.
Thank you, Dr. Pranay. I now invite Dr. Parda Saradi to give us a talk on management of acute MI, the medical aspects of it.
Good afternoon, everyone. Thank you for giving me this opportunity. Today, my topic for the presentation is the medical management of acute MI. So, whenever a patient presents with the chest pain to the pre-hospital EMS providers, they have to be given 150 to 300 mg of aspirin, which is a chewable form in a non-interact coated formulation. The goal is quickly to block the thromboxane active formation in the platelets, and who are taking the previously on nitroglycerin, they have to take sublingually. If still there is no improvement in the pain after 5 minutes, they have to seek medical help immediately. Coming to the acute pharmacotherapy, whenever a patient presents with chest pain with a saturation of less than 90%, oxygen supplementation has to be done, which is a class 1 recommendation according to ESC 2023. And for immediate pain relief, the IV morphine, which is in the dose of 5 to 10 mg, plus metoclopramide. The rationale of combining metoclopramide to the morphine is there is a delayed gastric emptying because of the morphine, and to promote the gastric emptying and also increase the mobility of the gut, and also to increase the absorption of the antiplatelets that are given in the acute situation, the metoclopramide is added. And the mechanism of action of morphine is there is reduced oxygen consumption as a result of decreased preload and negative inotropy and chronotropy. And IV nitrates to be given to relieve ischemia. The contraindications being the hypertension, RV infarction, severe AS, and also patients who are on PDE5 inhibitors like sildenafil in the past 24 to 48 hours. Coming to fibrinolytic therapy is an important reperfusion strategy for STEMI patients presenting within 12 hours of symptom onset when primary PCI cannot be performed in a timely manner. So it prevents 30 early deaths per 1,000 patients treated within 6 hours of symptom onset. And successful reperfusion is associated with significant improvement in ischemic symptoms and more than 50% ST segment resolution and also hemodynamic stability. So the goal of the fibrinolytic therapy is it should be initiated within 10 minutes of the STEMI diagnosis. In a meta-analysis, pre-hospital fibrinolysis compared with in-hospital fibrinolysis reduced early mortality by 17%, particularly when administered in the first 2 hours after the symptom onset. The pharmaco strategy, invasive strategy, that is the fibrinolysis immediately followed by the PCI within 3 to 24 hours, showed a significant benefit and also comparable results with the primary PCI in the meta-analysis. So what are the contraindications? The absolute contraindications being the previous intracranial IC bleed or stroke of unknown origin, and also ischemic stroke in the preceding 6 months, and CNS damage or neoplasms or AV malformations. And also recent surgery and also major trauma and GA bleed within 1 month, and also no bleeding disorder excluding the menstruation, and also aortic dissection and non-compressible punctures in the last 24 hours. So the related contraindications are advanced liver disease, non-peptic ulcer, and also infective endocarditis, and also prolonged or traumatic resuscitation. So these are the comparison of the approved fibrinolytic agents. The most commonly used are the streptokinase, retiplase, and also tenecteplase. So out of this, the bolus administration is for the retiplase and also the tenecteplase. So antigenic form is seen in the streptokinase, and also allergic reactions are quite common with streptokinase. So that's why if the patient has taken streptokinase in the past 6 months, the chances of allergic reaction is also possible for the next injection. So that's why within 6 months there should not be any previous history of streptokinase for the administration. So systemic fibrinogen depletion is more marked in the streptokinase, and the 90 minutes patency rate, that is the TMV3 flow, is higher with retiplase and also the tenecteplase with about 85%, and it is lower with streptokinase, that is 68 to 75%. So anticoagulation is another important component of the initial treatment of ACS and of the periprocedural treatment for ACS. So these are the common anticoagulants used in the management of the ACS. That is heparin, low molecular weight heparin, and also fondaparinux. Out of this, synthetic form is the fondaparinux, and it's a low molecular weight form. And these are specifically target the factor 10A and also 2A. Out of that, only fondaparinux only targets the factor 10A. So the bioavailability is lower with heparin, and also its half-life is only 1 to 2 hours. So there is no renal dose modification in patients who are taking unfractionated heparin. And also the protamine is the only reversal agent for heparin and also complete, whereas a partial reversal can be seen with low molecular weight heparin. And the dose for the protamine for the reversal is 1 mg per 100 units of the heparin administered. And the heparin-induced thrombocytopenia is quite common with heparin, unfractionated, and it is usually the incidence is less than 5%. And also for low molecular weight heparin, it is less than 1%, whereas it is not seen with the fondaparinux. So these are the dosage schedule for the anticoagulants. So unfractionated heparin should be given in the dosage of 7 to 100 units per kg to target a APTT of 60 to 80 seconds. And also enoxaparin should be given in the 1 milligram per kg BD for a minimum of 2 days or until revascularization happens. So even for during PCI, enoxaparin can also be used, and if the previous dose is less than 8 hours, they can continue. There is no additional dosage. If there is an additional dosage is required, if it is more than 8 hours of the last dosage, and the additional dosage is 0.3 milligram per kg enoxaparin. So bivalirudin can be used in the patients with heparin-induced thrombocytopenia. So this is a 0.75 milligram per kg IV bolus followed by the infusion of 1.75 milligram per kg per hour for 4 hours after the procedure. So fondaparinux is not used in the setting of the STEMI because of the guide catheter thrombosis, and it has to be used with unfractionated heparin only. However, it has a role in the NSTEMI patients who are opting a strategy of the, in which we are adopting a strategy of the delayed invasive strategy, that is more than 24 hours invasive strategy. So antithrombotic therapy. Aspirin and also potent P2 white wall receptors like prasugrel or ticagrelor is recommended as the default DABT strategy for ACS patients. However, clopidogrel which is characterized less effective and also more variable plated inhibition, should only be used when prasugrel or ticagrelor are contraindicated or in patients with high bleeding risk. In addition, the use of clopidogrel can be considered in older patients, that is more than 70 years. So these are the dosages of the antiplatelet drugs. So coming to the prasugrel, it has to be given in the loading dose of 60 mg followed by maintenance dose of 10 mg. And in patients with less than 60 kg weight and also more than 75 years, the dosage should be 5 mg OD only. And also for the prior stroke is a contraindication for the prasugrel. So ticagrelor, the loading dose is 180 mg orally followed by a maintenance dose of 90 mg BID. So cangrelor is now gaining popularity because it can be used in patients with a P2 white wall receptor antagonist naive patients. So it should be given in a bolus of 30 micrograms per kg IV followed by the 4 micrograms per kg per minute for at least 2 hours or for the duration, entire duration of the procedure. So IV antiplatelets, there is no strong evidence for the additional benefit with the routine use of GB2B3 inhibitors in ACS patients scheduled for coronary angiography. However, their use should be considered for the bailout if there is any evidence of no flow or a thrombotic complication during the PCI. And the cangrelor is a direct reversible short-acting B2 white wall inhibitor that can be used during the PCI. So this is the lipid-lowering therapy. So if the patient is having prior treatment of lipid-lowering therapy naive irrespective of the LDL cholesterol values, so we have to initiate the high-potency, high-intensive statin therapy, and also we have to maintain the LDL cholesterol less than 55.
Dr.
So if the
Parsati,
patient...
I think we'll end.
Yes. So coming to the beta blockers, it has to relieve the ischemic pain and also reduce need for analgesic and also reduce infarct size and also life-threatening arrhythmias. The contraindications being signs of heart failure, evidence of a low output state, and PR interval more than 0.24 seconds, and also second or third degree AV block. So coming to the RAS inhibition, it has a favorable impact on the ventricular remodeling, improvement in hemodynamics, and reduction in the congestive heart failure admissions. So these are the AC inhibitors and aldosterone blockade. So this is the trials for the long-term benefits of the AC inhibitors in the, this is SAVE trial, AIR trial, and also TRACE trial. This is enalapril and also trandopril. So it showed a relative risk reduction of 26% and also mortality benefit in these patients. So this is an EPICIS trial where epinephrine 25 milligram per day is titrated to 50 milligram per day for high-risk patients following STEMI, and it showed a 50% reduction in the relative risk of the mortality. And in patients with STEMI, it is ideal to maintain the blood sugar levels less than 180 milligram per deciliter, so that whether it is a complicated or uncomplicated course STEMI patients. So these are the cardiac arrhythmias in MI. So for the patients with ventricular tachycardia and ventricular fibrillation, we have to go with antiarrhythmic agents, and also we have to go for defibrillation. And sometimes we have to, in patients with bradycardia or also AV blocks, we have to go for the pacing. It can be temporary, and also if the patient is still dependent on the temporary pacemaker, we have to go for the permanent pacemaker. Thank you.
Thank you, Dr. Parda Saradi. Dr. Kavya will be presenting to us on staging and management of hypertension.
Today I'll be talking about the staging and management of hypertension. I'll just try to focus on the major guidelines and the different stages of hypertension, not going to go in too much detail about each drug. Just a few statistics. The prevalence of hypertension in India on average is around 30%. That's for urban population, it's around 33.8%, and in rural India, it's 27.6%. Out of them, only around 25 to 50% are actually aware that they have hypertension, and only 12% have it under control. Hence, it is extremely important to diagnose early and increase awareness regarding hypertension. So coming to the definition and staging, they have the European guidelines and the American guidelines. The EAC guidelines were published in 2018 and recently revised this year. The American Heart Association was in 2017. So the major difference between the two is that according to the ACC, hypertension is above 130 by 80 millimeter mercury. That is stage 1. And stage 2 is above 140 by 90. And hypertensive crisis is above 180 by 120. The European guidelines, 130 to 139 and 85 to 89 is considered as high normal, but actually hypertension, they have labeled it from beyond 140 by 90. So 140 to 159 is grade 1, and grade 2 is 160 to 179, and beyond that it is grade 3. So another important thing is this is all office blood pressure, and the guidelines emphasize a lot on also ambulatory blood pressure monitoring as well as home blood pressure monitoring, and it's especially important in the case of white coat hypertension or masked hypertension. So accordingly, office blood pressure, as I mentioned in the previous slide, according to the European guidelines is above 140 by 90, and ACC it's above 130 by 80. When it comes to ambulatory blood pressure monitoring, the 24 hours, the mean 24-hour pressure is above 130 by 80 according to European, and 125 by 75 according to ACC guidelines is defined as hypertension. And as we know that in the night, it should dip by around 10 to 20% reduction in systolic blood pressure. And if it doesn't do so, those patients are labeled as non-dippers, and they are under increased risk of cardiovascular events and target organ damage. So for the nighttime, blood pressure is around above 120 by 70 or 110 by 65. And home blood pressure monitoring, above 135 by 85 according to European, above 130 by 80 in ACC guidelines. So what they have stressed upon, and which is extremely important, is how the blood pressure is measured in office and especially at home, because the patient has to be educated on how to use it. First of all, the mercury sphygmomanometers must be replaced by aneroid or oscillometric blood pressure machines. The patient should be sitting comfortably with feet on the ground and sitting upright. They should not have consumed caffeine in the previous 30 minutes or exercised. They should sit quietly for around 3 to 5 minutes. They should not talk during the measurement, and it should be measured at the level of the heart. And in office, it should be 3 measurements taken at least 2 to 3 minutes, at least 1 to 2 minutes apart, and the average is taken between them. And in home readings, it should be at least 2 readings, ideally taken 1 week before the patient is going to go for their checkup. And you can see on the right side, that is a ABPM machine. So the patient can just wear it and move around and do the regular activities, and then we can assess accordingly. Also, the machines which are taken at home should be brought annually for validation in the hospital to check the accuracy. So accordingly, we differentiate the white coat hypertension or masked hypertension. So if the patient is having a office blood pressure above 130 by 80, despite 3 months of a trial of lifestyle modification, and then a daytime ABPM or a home blood pressure monitoring is still showing less than 130 by 80, it is defined as a white coat hypertension. So lifestyle modification should be advised, but yearly checkups are required because they are prone for target organ damage. And on the other hand, masked hypertension is when the office pressures are below 130 by 80, but at the home blood pressure or the ABPM pressures are above 130 by 80, that is masked hypertension, and they do require antihypertensive therapy. Coming to the management, I'm just going to stress upon the major guidelines. Of course, lifestyle modification is extremely important, and each modification can reduce the pressures by a certain range. So weight reduction, every 1 kg reduction in the weight reduces the systolic pressures by around 1 mmHg. So for 10 kgs, around 5 to 20 mmHg pressures will drop. And importance of a healthy diet, that is a DASH diet, that is a lot of legumes and vegetables and nuts, that reduces it by 8 to 14 mmHg, which is a very important modification. Reduced dietary intake of sodium reduces it by 5 to 6 mmHg. Increased potassium has been recently introduced in the guidelines, and that reduces by 4 to 5 mmHg. Physical activity of around 20 to 30 minutes of moderate intensity activity for at least 5 days in a week reduces it by 5 to 8 millimeters mercury. And of course, alcohol consumption should be less than 1 drink in women and 2 drinks in men to reduce the pressures by 2.4 to 4 mmHg. And of course, total abstinence of smoking is necessary. So when to initiate antihypertensive therapy, there have been a lot of trials and a lot of guideline variations regarding this. And finally, according to the American guidelines, you have to risk stratify the patients, especially if they're in stage 1 hypertension. That is between the range of 130 to 139 and 80 by 89. You have to put a 10-year ASCVD risk score. So according to the risk, which includes gender and the systolic, diastolic blood pressure levels, lipids, smoking, presence of diabetes, and medication use, they are either more than 10%, which is high risk, or less than 10%, which is low risk. So if they are low risk, they can be treated non-pharmacologically and reassessed after 3 to 6 months. But if they are at high risk, even despite being in stage 1 of hypertension, they must be treated with BP lowering medication and reassessed after 1 month. If after a month the pressures are under control, you can continue and reassess after 3 to 6 months. If not, you have to up titrate the dosage. Of course, stage 2 hypertension has to be treated with BP lowering medication. According to the European guidelines, they use a scoring system called score risk estimator, and they also include the importance of hypertension mediated organ damage. I have a small slide about that. So in grade 1 hypertension, if they are at high risk, that means even irrespective of the score system, if they have cardiovascular disease, renal disease, or HMOD, that is hypertension-mediated organ damage, they must be treated with medication. But if they are in the low to moderate risk, they can be treated with lifestyle intervention for 3 to 6 months. If still on the higher side, then they have to be treated with medication. Grade 2 and 3 have to be treated with drugs and reassessed every 3 months. So for the hypertension-mediated organ damage, brain MRI is required because white matter changes and small microinfarcts can be detected early. And carotid intermedial thickness, carotid femoral pulse wave velocity for the arterial involvement, and ankle brachial index, ECG and 2D echo pictures suggestive of LVH, and of course reduced EGFR and microalbuminuria, and fundoscopy for ophthalmological changes. Now coming to the treatment goals, the ACC-AHA depends on the ASCVD risk. So it is a class 1 indication to have the treatment target as less than 130 by 80 in high risk individuals, and even in low risk it is considered as less than 130 by 80 to be the target, because it was found that the cardiovascular events were much less when there was more stringent control. According to the European guidelines, it depends on the age. If they are below 65 years, it should be less than, they say 140 by 90, but ideally try to reach at least below 130 by 80, but not lower than 120. And above 65 years of age, they say that it should be less than 140 by 80, but if they are tolerating it, you can go up to 130 by 80. So a broad way to remember is to keep the targets as below 130 by 80, and according to AHA, irrespective of the presence of comorbids. So the treatment algorithm is that both of the guidelines suggest that the initial should be a combination therapy or a single pill of a dual combination, which includes 4 first-line medication, that is ACE inhibitors or ARBs, a calcium channel blocker, and a diuretic. So first it should be ACE inhibitor ARB plus a diuretic with or without a calcium channel blocker. Monotherapy can be considered in grade 1 hypertension. But then if the patient is not responding and you've treated for 3 months, then you have to up-titrate it and add another one. So it becomes a triple combination, but ideally in a single pill. Single pill combination has been reiterated in the guidelines. And if it's still not responding, then you can add a mineralocorticoid receptor antagonist, ideally spironolactone, or a different diuretic, an alpha blocker or a beta blocker. The European guidelines advise beta blockers to be the first-line treatment, but according to ACC, it should be added if the patient has comorbids such as heart failure or post-PTC, post-MI, or stable CAD.
I think Dr. Kavya should end up now.
Okay, I'll just talk about resistant hypertension. Resistant hypertension, first we need to confirm that it is treatment resistance. That is, the pressures above 130 by 80, despite 3 antihypertensive, one of them being a diuretic. And then you have to include pseudo-resistance, that is non-adherence or incorrect, inaccurate measurements. And then identify whether they are adhering to lifestyle changes. Rule out secondary causes of hypertension, discontinue any drugs which are causing hypertension, and then maximize diuretic therapy, add a mineralocorticoid receptor antagonist or alpha blocker, beta blocker. And the newer guidelines according to ESC say that for CKD stage 1 to 3, you can even consider renal denervation, but stage 4 to 5, try to put a centrally acting agent as well. That's it.
Thank you. Thank you so much. I now invite Dr. Lingaswamy. Is here, okay, to speak to us on transcatheter-based treatment in cyanotic congenital heart disease. All the speakers have kept their talks very crisp, to the point, and precise. We really appreciate the speakers in their efforts to give these presentations. Each one of them have been excellent. Thank you. Go ahead.
Good evening all. So myself is Lingaswamy, pediatric cardiologist in KIMS Sunshine Hospital. Today I am going to elaborate various transcatheter based interventions in congenital heart disease spectrum. So basically what is transcatheter based intervention? So we all know that one venous system is carrying the deoxygenated blood and pumping into the heart and lung. After circulation, after oxygenation, it's recirculated back into the various peripheral organs. So it's like use of the great vessels, either transfemoral, transvenous approach like greater femoral artery, femoral venous, carotid, axillary artery approach, jugular venous approach. With these approaches, we enter the heart with the various catheters and make underlying cardiac conditions. So treating the underlying condition or stabilizing the patient. So what is the advantages with the open heart surgery with the transcatheter base? It's a less invasive approach, fast recovery, and also when we child is subjecting to open heart surgery, the child has undergone to cardiopulmonary bypass. It's causing this various complications, especially neurological issues. So it's a very helpful in the critically ill children. So in this picture you can see this one, various type of transcatheter based interventions at the atrial level, ventricular level, pulmonary artery level, pulmonary venous level, and also ductus arteriosus level. So basically traditionally congenital heart diseases are cyanotic group and acyanotic group. In that acyanotic group, major things are left to right shunt and obstructive lesions. In the left to right shunt, atrial septal defect, ventricular septal defect, patent ductus arteriosus, and obstruction of the aortic wall, pulmonary wall, coarctation of aorta. So whatever the intervention we go in the acyanotic group, or most of them are like a primary effect is the ultimate of things. Very less likely need of further intervention. If you come to the cyanotic group, transcatheter interventions are basically act as a palliative, maybe a relieving of cyanosis, preparing the child for next phase of surgery. So I will go to some of the transcatheter interventions in the next few slides. Most commonly, as I discussed previously, left to right shunt and obstructive lesions, less commonly balloon aortic valvotomy, pulmonary valvotomy, and rarely we'll go for PDA stenting hybrid procedure. So let's go to the one by one some of the interventions. So you can see in this picture, I am seeing the heart atrial septum from the right atrial view. The central thing is the secondum ASD. That defect is which is near the tricuspid valve is the primum ASD. Most of the ostium secondum ASDs is closed by the transcatheter base. All primum ASD, sinus venous ASD is not possible to close with the transcatheter based. You can see in this picture, this is a 10-year child, weight is 1040 kgs, having the moderate sized ASD. In the upper the defect is there, which is shunting the left to right shunt, and also I am projecting the various type, how is the profiling of the ASD in the different views. Same patient underwent the transesophageal echocardiography to assess the anatomy of the defect and also how much size and how is the rims for that one. So for this child we subjected to the cardiac this transcatheter. So we entered the right femoral venous approach into the heart. So you can see this, the catheter is entering the pulmonary vein. Then we taken the stiff wire sheath through this one. You can see here I am deploying the device to pulmonary venous approach. So left atrial disc open up and I pulled the disc towards the atrial septum, and the device is reconfirmed the position in the different views. You can see in this one, this is the prototype of the device. What we can see, we are doing here. This one, the left atrial disc and right atrial disc, there is a connecting wedge inside. This is the membrane is there. It will be aggregate the platelets and also the shunt will be abolished. The post this one, you can see here the device is completely occluded that atrial septal defect and also well away from the AV walls, and there is no residual leak across that one. So you can see here, this is a 3-year child having that multiple VSDs, parasternal long axis. You can see this VSD is the perimembranous region having the multiple defects is there. You can see here, this is the defect. So we approached this child into the transcatheter VSD device closer. You can see this, I taken the catheter through the femoral arterial approach. I put the catheter in the left ventricle, then injected the contrast. So you can see this filling of the right ventricle. Then I taken the arteriovenous loop. This is called to stabilize, to track the sheath into the aorta. So you can see this in this picture. You can see that disc is open up and pull the device and putting the device across the ventricular septal defect. You can see this. I will show the final angiogram. So this is the angiogram we put exactly at the level of the perimembranous region. All defects are almost as covered. There is no residual leak across that one and no AR. So most of the VSDs which were tackled in the cath lab are small to moderate size. Still large defects are need to surgical closure. Thus not all the VSDs are possible to close. Some of them like inlet VSDs, malaligned VSDs, outlet VSDs is not possible to close to device. So another child you can see here is the child is 1-year child having recurrent respiratory tract infections. So there is between the two great arteries there is a communication called as a PDA. So we done this child also PDA device closure. You can see here the PDA we entered through the femoral venous approach. Then we taken the device, the post-device closure, the device is in position, there is no residual leak. So the most of the PDA device closure success rate is very good because it's outside structure. So, but still there is PDAs which is larger than 4 mm and less than 3 months. And having the CCF, most probably these, because if you put the device, there is a chance of aortic obstruction and LPS stenosis. So these cases only need of device closure. So another case is for a 10-year child, weight is 20 kg, having the hypertension and dyspnea and exertion, having the severe post-subclavian coarctation of aorta. You can see in this picture, we taken the femoral arterial approach. So into the ascending aorta, we injected. You can see there is a discrete coarctation post-subclavian region. So we measured the measurements. The gradient across the coarctation is 38. So it's a significant. So what we done is the isthmus is very narrow, 4 mm transverse arch and post-stenotic dilatation. So what we done is, so we taken the balloon, and you can see here balloon and stent is crumpled over the balloon. So the next angio, you can see that the injection into the, this is the sheath. Over that is the, inside that is the stent. You can see here, stent is exactly put across the stenotic segment. So inflated at the level of the isthmus region. The stent, we appropriately measured that. This is the balloon, is the Cook balloon, and the stent is the, we taken is the Andra stent. It's an uncovered stent because if a stenotic critical coarctation segment is there less than 3 mm and aneurysmal segment is there, better go for those cases. Covered stent. Even in our shelf, whenever you take for coarctation, we have to keep as a anytime dissections will happen. So we have to keep the covered stent. So post stenting, the pressure gradient is across the coarctation segment is less than 3. The result is good. There is a pulses are very good. So you can see this is the another 2 days child having the severely cyanotic of saturations of less than 70%. Cardiomegaly is there. Oligemic lung fields. So echo showing that there is a small RV and critical pulmonary stenosis. This is the duct-dependent pulmonary circulation. Because the flow across the pulmonary valve is very limited, the duct is supplying the pulmonary arteries to the sinus.
You'll have to come down, please.
So what we done is we taken the femoral venous approach. So we balloon dilated that segment. Then post balloon dilatation, you can see this valve is well opened. Child is completely away from the prostaglandin. Then so this is the. So you can see this is a complex congenital heart disease. Just I will show the child having the single ventricle physiology. You can see this. The ventricles are both like a common ventricle, and both outflow tracts are coming from the right ventricle. The pulmonary artery is very, very stenotic, and the pulmonary artery flow is dependent upon the ductus arteriosus. This is the duct-dependent pulmonary circulation. So what we done is we taken the axillary artery approach. We put the stent across the PDA level. So we taken the axillary artery approach. So we taken the stent through this one, and we make that pulmonary blood flow is improved, the cyanosis is improved. So this is another 1 month child having the critical TAPVC. It means like supracardiac CVC, severely obstructed. You can see all pulmonary veins are combinedly joining into the innominate vein. Here is the obstruction is there, vertical vein level. So what we done is, you can see here, we put the stent across the exactly at the narrowing region. Then the pulmonary venous drainage is improved. So what will happen? The child is improved symptomatically, then later electively we taken for surgery. So what are the, I told you so many of cardiac interventions so far now, but only 20 to 30% of interventions are only possible by transcatheter. Most of them need surgically, and also we have to depend most of them adult hardware things. So I will conclude that one is a good alternative CHDs by transcatheter based. It has its own merits and demerits. It's a depend upon underlying CHDs and availability of hardware, financial concerns. Thank you so much.
Yeah. Now I call upon Dr. Sashikanth, my co-chairperson of the session, to speak on fine-tuning post-acute coronary syndrome cardioprotection, the case for early and aggressive lipid lowering. Over to Dr. Sashikanth.
Okay. Thank you. At the outset, good afternoon, everyone. I thank Dr. Kasturi Sridhar for taking this initiative. No? Sorry, I want to take this. Okay. Greatly appreciated, Dr. Sridhar, for this initiative. The topic which has been given to me today is on lipids, and we thought we should talk more appropriate on post-acute coronary syndrome cardioprotection, the case for an early and aggressive lipid lowering. We all know that patients who present with acute coronary syndrome are at increased risk of experiencing recurrent cardiovascular events. And for these patients, the lipid management should be undertaken in the context of a comprehensive global risk reduction, which includes lifestyle adaptations, risk factor management, and the implementation of cardioprotective drug strategies like beta blockers, antiplatelets, and statins. Despite the knowledge of clinical benefits of lowering LDL cholesterol, we have not been able to achieve these goals for the lipid lowering targets easily. And if you look at this American College of Cardiology ACC guidelines, they have grouped almost all the patients with atherosclerotic cardiovascular disease, be it chronic or acute, in the very high-risk category, wherein the treatment goal for LDL cholesterol is 55 millimeters of mercury. And to achieve this, it's quite difficult. The patients with ACS are automatically classified as this very high-risk group in both the European Society of Cardiology and the American College of Cardiology recommendations. And statins are the cornerstone of therapy for this lowering this LDL cholesterol, with more than 25 years of mounting evidence in their efficacy and in their proof as good lipid-lowering drugs. The goal is about 50% LDL reduction from baseline and an LDL goal of below 55 milligrams per deciliter. If a patient has suffered a second event, a second vascular event within 2 years on maximally tolerated statin therapy, the LDL goal goes below 40 milligrams per deciliter. But can we reach these goals with monotherapy? The answer is difficult, but yes, it is achievable with today's drugs being available there. If you look at this diagram here, with the ACC/HA guideline target of less than 70 milligrams per deciliter, 1 in 4 patients can achieve the target LDL cholesterol of less than 70 milligrams per deciliter. But the ESC guidelines have set the target as less than 55, which is more difficult to achieve. Of course, they are more stringent in their guideline implementation, and only 1 in 10 patients, or 9 in 10, did not meet the ESC guideline target. Now, this is a very, very dismal picture what we have today. So like we use the pack years for a smoker who has smoked 1 packet per day for 10 years, 10 pack years, we can move the subject of having cholesterol years for CV reduction, for CV cardiovascular risk prediction and treatment. It is basically the cumulative product of the quantum of LDL cholesterol and the duration of the exposure to the arterial wall for this LDL levels, which make us decide the severity with which the coronary artery disease is going to manifest in these patients. So the cholesterol years is one concept which can be said, but why is this important? This is important because patients with acute coronary syndrome have recurrent events and they have vulnerable plaques in their coronary arteries. We have some insight from the intracoronary imaging wherein patients with acute coronary syndrome have more high-risk plaques in their non-infarct-related arteries, high plaque burden, thinner fibrous cap, more lipid accumulation, more inflammatory cell accumulation, and they have frequently a lipid-rich plaque which are more likely to rupture. So the emphasis is more on an early plaque stabilization. Pathophysiologically, acute coronary syndromes do have this thin fibrous cap? And do we have evidence to tell that statins as a therapy increase the thickness of the fibrous cap, thereby they stabilize the cap? And in this study with OCT in patients with heart disease, they noted that patients who have been introduced to statins early in the disease, early statin group, there was a significant increase in the thickness of the fibrous cap, thereby stabilizing the cap and reducing the cardiovascular events, in addition to the pleiotropic benefits what is seen with this statin group of drugs. The European Society of Cardiology and have given a treatment algorithm wherein they said a stepped care approach is advised, and this is how their guidelines algorithm goes. Initiate with a high potency statin at the highest recommended dose or a tolerable dose to reach the goal. And if the goal is not reached, in 4 to 6 weeks' time, you add a second drug, a non-statin drug in the form of an ezetimibe. And again, if in a matter of 4 to 6 weeks, if the LDL goal is not reached, do consider the newer lipid-lowering drugs which are available, like PCSK9 inhibitors. If you start a patient with a moderate intensity statin, probably the LDL reduction probably would be up to the tune of 30%, with a high intensity statin to the tune of 50% reduction in the lipid levels. Adding a PCSK9 inhibitor to the statin therapy and with ezetimibe lowers the LDL cholesterol to the tune of 85%, which most of the patients do achieve there. The dyslipidemia guidelines have classified all the atherosclerotic cardiovascular disease, both chronic and acute, in the same fashion. And the most important thing is that there is a significant therapeutic inertia. This is a Swedish sweetheart study, a nationwide study on acute MI patients who were admitted in 74 centers across Sweden from 2018 to 2019, and about 40,000 patients were studied in this at discharge, cardiac rehabilitation, and 1 year after the index event, and they found that most of the patients at discharge had less than 50% of the patients were prescribed a high-intensity statin therapy. This is very important because most of them would not reach to goal if they were not on statin therapy, and add-on therapies were much less. If you look at this cascade, wherein again in the sweetheart study, the statin intensity on admission at discharge, cardiac rehabilitation at 1 year after follow-up, about 40,000 patients studied, about 10% of the patients had a rise in their LDL cholesterol. Another 20% of the patients had no reduction or an increase in the LDL cholesterol. About 0 to 50% reduction was seen in the blue graph, what you have seen here, and about more than 50% reduction was seen in the green graph there. If you look at the events, MACE, major adverse cardiac events, was higher in the group wherein there was no reduction or increase in the LDL cholesterol, and again a higher event rate in the group which had a 0 to 50% reduction in the LDL cholesterol. The green bars represent a greater than 50% reduction, showing the lowest cardiovascular event rate. Again, there is a significant gap between clinical guidelines and clinical practice. The Da Vinci study was one such case wherein a European Union-wide observational study on the use of lipid-lowering therapy in the year 2017-2018 has very clearly shown that moderate intensity statin therapy is used to the maximum, about 43%. High intensity statin therapy, about 1/3 of patients. The combination usage was less than 10%. Again, this is a wake-up call for us, showing that under implementation of the guidelines do promote recurrent cardiac events, and we are not treating them to goal. After the Da Vinci study, the Santorini study was shown that, again, about 9,000 patients studied across the European Union, 14 countries, and they have seen in the year 2020-2021, quite contemporary trial, with the primary and secondary setting, despite LDL cholesterol levels above the recommended levels, only 54% of the patients reached the target with monotherapy, and 24% were using the combination therapy of statin, high-dose statin, and ezetimibe. The goal achievement in the very high-risk group was only about 20%. And mind you, at 20% of the patients were not on lipid-lowering therapy, in spite of them being on having had an acute coronary syndrome. So, most of the times it's inadequate statin treatment intensification or insufficient use of add-on therapy like ezetimibe or a PCSK9 inhibitor. There are a lot of trials which have been done almost 2 decades ago. The Prove It trial, the Miracle trial have very clearly shown that high dose intensity statin therapy to the maximal tolerated doses are the way to go to reduce the LDL cholesterol, thereby reducing the recurrent cardiovascular events. The discontinuation rate with high dose statins is quite less, to the tune of about 1 to 2% or 3%, and they are usually well tolerated there. The Improve It trial was another trial which has shown a place for ezetimibe in the management of hospitalized patients with acute coronary syndrome, in addition to an add-on statin therapy. Simvastatin monotherapy versus ezetimibe with a combination of simvastatin has clearly shown a significant reduction in the cardiovascular events on a median follow-up of 6 years. So statins and ezetimibe are two important drugs. Now we have a newer molecule which is available, the PCSK9 molecule inhibitors, which have established a role in for themselves in the management of the high LDL cholesterol group, especially the familial hypercholesteremia groups. Alirocumab was one such molecule, and evolocumab a second molecule. The Odyssey outcome trials was a multi-center randomized trial with 18,000 patients, injection given subcutaneously, 75 milligrams every 2 weeks, with the primary endpoint of non-fatal MI, fatal MI, unstable angina, with a median follow-up of about 3 years. More than 50% reduction in the LDL cholesterol was seen, and again a significant reduction in the cardiovascular events there. The 4-year trial again has shown a significant improvement in the cardiovascular events. They had some plaque assessment with intracoronary imaging in these acute coronary syndrome patients with IVUS as well as OCT, and both of them plaques have clearly shown that there is a significant reduction in the atheroma plaque volume. They are about more than 90% of the patients have reached their target LDL cholesterol. The atheroma volume, as studied by intravascular ultrasound as well as by the OCT, has clearly shown a 2% reduction in a span of 12 months. There is a significant increase in the fibrous cap thickness, which is again a very important factor for stabilizing coronary artery disease, unstable plaques. There is a decrease in the macrophages present in the endothelial wall, again telling us the plaques are getting stabilized with this group of drugs. And what was important was the prescription patterns are very important. We have to improve our lipid management in these patients with acute coronary syndrome. Basically, at discharge, most of these patients should be on high-dose intensity statin therapy. If necessary, adding an ezetimibe at the first go itself rather than taking a little time to add on these drugs. This is a guideline recommendation, a combination therapy as a straightaway in high-risk patients that will improve the patient compliance as well as reduce the recurrent cardiovascular events. These are the European Society of Cardiology guidelines, which have very clearly shown that add-on therapy with high-dose statins, adding ezetimibe would make a lot of difference. Adding PCSK9 inhibitor, again, is a very important way to go about. Concluding my presentation, lower is better. We need to start early. Striking early and striking strong is very important. Intensive, aggressive lipid lowering is important. This not only stabilizes the plaque, but also leads to a regressing the plaque. Diet and lifestyle modification are the sheet anchor. Risk factor control is very important. And add on non-statin therapies in the form of bempedoic acid, ezetimibe, eicosapentile, inclisiran is going to be available very soon from December, and other monoclonal antibodies which target different levels in the production of lipid lowering therapies is very important again. Thank you for your patient hearing.
Thank you, Dr. Sashikanth, for your excellent presentation. Now, I call upon Dr. Praneeth Polamuri to give a very interesting talk. Can a heart attack occur when ECG, 2D, echo and TMT are normal? Are we missing something? Over to Dr. Praneeth Polamuri.
Yeah. So I think I will follow up what Sashikanth sir has started. We all hate heart attacks, and sir has mentioned about secondary prevention of heart attack, but my focus is on preventing a heart attack. It doesn't spare anyone, and we do not want anyone to have heart attack. And currently we have seen celebrities having heart attacks and having sudden cardiac deaths, which creates a lot of panic among young generation, and we all are witness to that, where people are coming to check up with ECG, Echo and TMT, whether I have the so-called risk of heart attack. So how do we answer this question? Do people have the risk of heart attack, and how do we risk stratify? Fortunately, few survived, and they could get the timely treatment. So people go to diagnostic labs or to come to hospital, get their cardiac health checkups, which include your ECG, Echo and TMT as well. But the main question, can we say that this patient's or this person's risk of having a heart attack has been reduced just because their ECG, Echo and TMT are normal? Now, if you look at the data, what does TMT say? TMT will be positive if the obstructive coronary artery disease is there, which means there is a diameter stenosis reduction of at least 70% or more. But if you look at coronary artery disease or the so-called acute coronary syndrome, most of the patients who have acute coronary syndrome, their stenosis is less. Only 60 to 69% of them are having obstructive coronary artery disease. And all these patients, their TMT will be negative. So how does an ACS occur? We have been introduced the concept of vulnerable plaque, which has been equally highlighted in the previous speakers. We know there is a lipid core, and the endothelium on top of the lipid core is thin, which can rupture and ultimately lead to an acute coronary syndrome. And this is why patients will have an acute coronary syndrome. So can we identify these vulnerable plaques or thin cap fibroatheroma and thereby predict the risk of a patient to have the so-called future ACS? How can we do that? We have intracoronary imaging, use of high-resolution intravascular ultrasound, OCT, which some of the pictures Dr. Sashikanth has already shown you. Can we detect a risk of having a future ACS by detecting vulnerable plaques? Unfortunately, no, which was shown in prospect study. Though we were identifying thin cap fibroatheromas, they were not equally reflecting into a clinical event. So what is happening? All those patients who have thin cap fibroatheroma, they do not end up having a clinical event. Most of these thin cap fibroatheroma may heal. They can become a fibrous plaque, or they can become thick cap fibroatheroma, and they may not produce a clinical event. So patient-related factors also do come into picture to produce an acute coronary syndrome event. So if the patient has a thrombus-promoting factors, you can end up having a clinical event, or if there are thrombus-resisting factors, then most of these plaques heal, and they ultimately develop into an obstructive coronary artery disease. So this patient, if he has already underwent an angiogram as well, where his ECG and TMT are normal, can we equally predict the risk of having an ACS, and can we clear them? So this patient who is having about 30-40% narrowing in the proximal LAD, can we say that this patient's risk is low? So to understand it better, there is a new concept of atherosclerotic plaque volume, which needs to be understood. So in this given picture, you can see there are A and B, where both the A and B are having a vessel wall diameter of 4 millimeters, but both A and B are not the same, because B has significant atherosclerotic volume in comparison to A. And over a period of time, if there is a 50% diameter reduction, which is again reported to be mild coronary artery disease by most of the angiogram, it is not the same. The amount of atherosclerotic volume to subject A to subject D is not the same. So subject D has a higher atherosclerotic volume in comparison to subject B. So the whole concept or the definition has now been changed from angiography-based definition to plaque-based definition. What do we mean by that? So for a patient who is having a 40% diameter reduction, who has a necrotic core sitting in, if these patients after treatment, if their necrotic core subsides or if they go into regression, even though there is a diameter narrowing increase from 42% to 50%, these patients are relatively stable, whereas in comparison, if the patients who have an increased necrotic core, though the 40% diameter reduction is still the same, these subset of patients are at higher risk. So concept of knowing the atherosclerotic volume and its implication or its future odds of having an acute MI are important. So quartile 1 here, who has a higher atherosclerotic volume, has a higher odds of having ACS. Subsequently, if you can reduce the volume by taking lipid-lowering therapy, your risk of having an ACS can be reduced. So we need to understand the concept that there is atherosclerosis which develops and it progresses over a period of time, ultimately leading to an ACVD event. So the whole goal is to detect an early atherosclerosis or a subclinical atherosclerosis. So this is the ACS risk or the ACS triangle that has been proposed, which is atherosclerotic plaque burden or the disease burden in a given patient, how active is the disease, and what are the hemostatic factors which can contribute a thrombus promoting event. So what is the atherosclerotic burden? How do we detect that? You can use coronary artery calcium score or the CAC score or carotid Doppler looking at intima medial thickness or peripheral ultrasound, or equally CT angiogram where there is no calcium, but there are those high-risk features which you all are aware of. To know about the disease activity, we have inflammatory markers. We all know that atherosclerosis is inflammation, and elevated high-sensitivity C-reactive protein will tell you that inflammation is active. And finally, hemostatic factors for a given patient. What are the contributing factors which start from age, genetics, diet, circadian changes, lack of adequate sleep, certain medications, environmental conditions like air pollution, and inflammatory conditions which can promote inflammation. They all can contribute for a given person to have ASCVD risk. So how do we approach these patients? So there are proposed risk scores, the pooled cohort equations, which again the previous speaker has highlighted. There is from American College of Cardiology and European Society of Cardiology. One commonly used is ACC. I will try to run through one of them. So you put in your data. There are apps also available. These are online calculators. And it gives you an estimated absolute 10-year ASCVD risk. And patients are stratified into 4 groups: low, borderline, intermediate, and high. And if the patient falls into low risk, you can ask them to do lifestyle modification. And if the patient falls into high risk, you advise them statin therapy. Borderline and intermediate, you can't leave them alone. You sometimes have to dig deeper. You try to look whether the patients have any risk-enhancing factors. And if they have any additional risk-enhancing factors, then you again try to consider giving them drug therapy in addition to lifestyle modifications. What are the risk-enhancing factors that we need to look into? Family history of premature ASCVD, males less than 40 years, women less than 50 years, primary hypercholesterolemia, which means LDL more than 160, metabolic syndrome, chronic kidney disease, chronic inflammatory conditions like rheumatoid arthritis, psoriasis, SLE, HIV/AIDS, ankle brachial index less than 0.9, history of premature menopause less than 40 years, or pregnancy-associated conditions like preeclampsia. And lipid markers, which are again quite popular these days, are persistently elevated triglycerides more than 175, hsCRP more than 2, lipoprotein little a more than 50, ApoB more than 130. So all are these risk-enhancing factors. And if the patient has risk-enhancing factors, again have a low threshold to start lipid-lowering therapy. So to take home point are that patients predicting our ASCVD risk for a given patient is difficult. It is challenging. And the run-of-the-mill ECG, Echo and TMT may not answer the question, and stress testing can be, it will be only positive if you have an obstructive coronary artery disease. So we need to understand the current concept has been changed from vulnerable plaque to atherosclerotic disease burden or the plaque volume. So the whole goal is to detect subclinical atherosclerosis by various tools, which I've already mentioned. And once detected, we need to prevent the rapid plaque progression and thereby an ASCVD event. Thank you for your attention.
Thank you, Dr. Praneeth, for being crisp and to the point. Thank you very much. We now move on to the valve symposium. I invite the first speaker, Dr. B V Purohit, to come out to the dais and give a talk on transcatheter aortic valve and mitral valve replacement. Dr. B V Purohit. Again, I thank all the speakers in the previous 2 sessions who have done an excellent job, crisp to the point, good messages being given there. Dr. Purohit, you're ready?
Okay. So, can I have that slide change? Yes. Thank you, Sashikanth sir, Sridhar sir, for giving this opportunity. And I'll be talking on the structural valve, which has come up as a new specialty in cardiology, and it is growing very fast. And to be very honest, I believe the first revolution in cardiology came when Grunzig did the angioplasty first. And I believe the second revolution happened when Alan Krieger did the first transcatheter valve replacement. And I'll be talking about what exactly is TAVR or TMVR and when do we do that. So TAVR or TAVI is basically nothing but transcatheter aortic valve replacement or implantation, and TMVR is transcatheter mitral valve replacement. These are all non-surgical techniques by which we can do the treatment of aortic and mitral valve diseases. We are all very familiar that a patient who has got a aortic or mitral valve or any valvular disease, the only treatment few years back was surgical. But nowadays, with the development of these therapies,
we don't have to send the patient for surgery. And they can safely be managed with these technology, and they can be sent home without any complication. And nowadays, with all the trial data coming up, which shows that these therapies probably, they're almost equal to surgery, or in some situation, they are better than surgical outcome. So this is what happens. This is a picture of a aortic valve. You can see on the left side, the valve is wide open, whereas on the right side, you can see it is highly thickened and there is tight stenosis. So this is exactly what we deal with in TAVR or TAVI. And we need to, here we don't remove the valve, we implant a valve inside this and expand it. So these native leaflets are plastered to the side, and the implanted valve, which has its own inherent valve inside it, starts functioning, and the patient is relieved of aortic stenosis. So, little bit about aortic stenosis. It is a disease which is considered even more dangerous than cancer, many of the cancer. If a patient who has got symptom, then the survival after onset of symptom is only 50% at the end of 2 years, and is only 20% at 5 years. And if he has symptom like angina, syncope, heart failure, you can see very clearly how the survival curve drops dramatically. So the moment a patient has aortic stenosis, we need to be very careful in terms of evaluating. If many a times we see that despite the diagnosis, people don't undergo surgery, and almost 30-40% they don't even undergo surgery whenever it is recommended. And the outcome is, if you don't undergo surgery, within 1 year almost 40% will die, and by 5 years almost 70% will die. Now this is the brief history. In 88, Alan Krieger did the first TAVI, and subsequently this is the initial conceptualized drawing done by Alan Krieger. And you can see very clearly he has created a valve here which is of a mesh, and there is a valve inside this, and he has kept it across the aortic valve, and then after he has deployed it, the valve which is there inside this framework, it starts working. This is the great man who did it on April 16, 2002. And this is a picture just after doing that procedure, and you can see the procedure also there. You can hear the valve, which was the initial valve. The first implantation, the valve deployed by Krieger was a balloon expandable, and the first self-expanding valve was implanted by Grube in 2005. And this is the diagrammatic representation. You can see this is how the valve looks. As I told you, the valve on the left side is normal, opens wide apart, whereas the one on the right side doesn't open. So we make a puncture in the groin, and through that we insert a needle, and through that a wire is tracked, which goes up. It goes across the stenosed valve, you can see here, and this is the stenosed valve, and then we push a balloon which expands it to some extent, and then subsequently the artificial valve is deployed across it. And then we put a pacemaker. If it is a balloon expandable, the pacemaker starts beating rapidly so that the heart becomes almost standstill, and you can deploy the valve safely without any chance of dislodgement. And once the pacemaker starts working, you can deploy a balloon expandable. In a self-expanding, you don't have to do it, just have to remove the catheter. And here you can see the balloon expandable valve. And in both the scenario, the valve is kept, and the catheter and the wire, everything has been removed. And you can see the valve, which is there inside the framework, has started working well, and you can see the lumen has become so wide apart. And on the left side, you can see the stenosed valve, how it was. So this is the difference. The patient gets relieved of the symptom, and the heart improves, and the survival also improves in this subset of patient. So this is the picture, stenosed valve. It is expanded, and now it is removed. TMVR is something similar. The problem is mitral valve is more dynamic structure, asymmetrical, and it's heterogeneous, and it can give rise to either a stenosis or regurgitation, and many a times there is a combination. So because of this complex anatomy and diseases which are affected, it is very difficult to design a valve which will exactly sit on the mitral valve position, unlike what we see in the aortic. And that's the reason why there is a challenge. And these are the various mitral valve which has come up as a something similar to transcatheter aortic valve, but they are still on development stage. We still don't know which one is going to work best. So all the companies have come up with their own valves, but the thing which is really established in mitral valve is when the patient already has a balloon expandable valve, we do something called as valve in valve, or valve in ring, or valve in MAC. So these are the three procedures which are already on a diseased valve, where you have already put a bioprosthetic valve and that valve is not working, and then you deploy the same valve which was used for, the same balloon expanding valve which was used for aortic stenosis, the transcatheter valve, that valve is deployed here. If the patient has a mitral regurgitation, then we do something called a mitra clip, which is also a type of TMVR, where we clip the flailing valve. And that also is, these are the two therapies. You can see this is the artificial valve which is stenosed. So same way we put a catheter across and then we deploy another valve which is balloon expandable and the valve is remaining. And this is how actually it looks like in the real world scenario. And this is a diagram of the mitra clip. You can see the red blood is coming from left atrium going to the LV. But here you can see it is leaking back. There is a jet which is going back. So that is mainly because the leaflet is flailing and they are not coapting properly. So that's the reason why when the ventricle is contracting, some of the blood is leaking back. You can see the flared leaflet here. This is a flared leaflet. This is a normal leaflet. So you can see how it has gone up, so, which is not allowing proper coaptation. And this is where we deploy the clip to hold this flailing and prevent it from, prevent the regurgitation. And for that, we again go to the groin and do a septal puncture. So this is the interarterial septum. Through this, the clip is coming out and the clip is inserted inside the mitral valve. You can see it is now directed towards the mitral valve, and you can see the blood is coming out. It is all done under fluoro and transesophageal echo under general anesthesia. The clip is lowered down, and you can see the clip is gradually lowered down, and this is all done, as I said, under transesophageal echo and fluoro guidance. And now this clip is going to catch hold of the two leaflets of the mitral valve. You can see now the leaflets have been catched and the clip is closed, and then we release the clip here. Once we are sure that yes, the regurgitation has come down and we have captured both the leaflets properly, the clip is closed, and you can see this is how we create and we oppose both the leaflets and the regurgitation is stopped. Now you can see we are removing the other things and the clip is only remaining, and you can see the leak which was happening is no more there. So this is the diagram how we do a mitra clip procedure. So these are the outcomes in all the scenarios. Valve in ring, VMAC, the procedure has been successful. Now what are the indications? When do we do it? The decision to treat AS has to be done by the heart team. We have to decide which patient has to go for this transcatheter system. But just to give you a brief, anybody above the age of 80 years, no matter what the surgical category, the preferred choice is a transcatheter. If the person is below the age of 80 years or 65 to 80 years and he has a very high risk of surgery, then also you have to send them for transcatheter system. But anybody who is below the age of 65 years, in that scenario, if the life expectancy is more than 20 years, we prefer always a surgical valve. But other than that, the moment the patient crosses beyond 65 years, whether he is low risk, intermediate risk, high risk, a surgical and the transcatheter, they have got almost same outcome. So we need to discuss with the heart team, and found suitable, the patient can go for this. And for the TMVR, we prefer it in failed bioprosthetic, and it is preferred in failed mitral annuloplasty ring. We call it valve in ring, and in severe mitral annular calcification also we can do it. And for mitral regurgitation, we do it as a mitra clip. So with this introduction about this transcatheter system, I close my talk. Thank you very much for patiently hearing.
Thank you. Thank you, Dr. Purohit, for being again very crisp and very good diagrams. I now invite Dr. Rajaram for his insights into TricValve. So we had an aortic valve and a mitral valve intervention.
Transcatheter device, it has got two components, one to be kept in the SVC and another one in the IVC. As you know, this TricValve is used in the functional severe tricuspid regurgitation. So as you know, I am not going into the details and all those things, but any functional TR will lead to RV dilatation, followed by tricuspid annular dilatation, and finally tethering of the tricuspid valve leaflet, which leads to the severe tricuspid regurgitation. If you see here, when severe tricuspid regurgitation is there, Initially, it increases the pressure in the RA, thereby it increases the pressure in the IVC and SVC. Finally, leading to increase in the volume of the RV also. That in turn leads to dilatation of the RV, dilatation of the RA, and ultimately leading to congestive symptoms, congestive cardiac failure, arrhythmias, and then death. So that is the reason you have to treat the tricuspid regurgitation. So whenever there is an increase in the pressure, both in the SVC or in the IVC, suppose if pressure is increased in the IVC, there is a increased congestion in the liver, or congestion in the stomach wall, or congestion in the kidneys. All these things lead to diuretic resistance. Even if you want to treat with the diuretics, it is very difficult to completely dehydrate the patient if the patient is in the congestive heart failure. As you know, as the tricuspid regurgitation is increased, its prognosis is very, very bad, irrespective of the congestive cardiac failure or the etiology. If you see here, overall survival of the tricuspid regurgitation when compared with the mild TR, the severe TR has the low survival rate, and also increased all-cause mortality is also very much high when patient is having severe TR, irrespective of the etiology as well as heart failure symptoms. So, what are the options available if the patient is having severe TR? Usually, surgical procedures are well established till now, like edge-to-edge repair or annuloplasty. But are there any percutaneous methods are available? Yes, there are certain coaptation devices are available, and also nowadays orthotopic devices are also present under the exploration till now, and also heterotopic devices are also available like TricValve. And there are two valves which are available. One is Sapien XT and then TricValve. Sapien XT is a balloon expandable valve. TricValve is a self-expandable valve. So each procedure, like surgical procedures as well as percutaneous procedures, has got its own favorable conditions or indications, or unfavorable conditions like contraindications. So these devices are the orthotopic devices. That means you will fix these devices in the tricuspid annular level to prevent the severe tricuspid regurgitation. Heterotopic devices are, like I said, Sapien XT or TricValve, which are kept away from the tricuspid annulus, like in the SVC and then IVC. So this is the algorithm we follow. Suppose if the patient is not fit for the surgery, then percutaneous methods, we will follow this algorithm. So only phase 3 trials which have completed or on the phase 3 trials are TricValve as well as Sapien 3 valves which are available. So this TricValve is indicated when patient is having high surgical risk or not willing for the surgery or maxed out medical therapy, if the patient is having unsuitable anatomy for the repair or presence of the pacemaker lead or peri-procedural imaging challenges are there. So this is the side view of the TricValve. TricValve contains two parts. One is to be kept in the SVC, another one is to be kept in the IVC. This is the end-phase view. This is the bioprosthetic material, bioprosthetic tricuspid valve. And the mechanism it is going to help is basically by keeping these valves in the SVC and IVC, it prevents the backflow into the SVC and IVC, thereby reducing the congestion in the organs, promoting the RV remodeling, and decreasing the symptoms. Finally, it may lead to the decrease of the mortality. So these are all the inclusion criteria or indirect indications where the patient has to be symptomatic in the class 3 or 4. It has to be significantly severe TR, and then LV function should be normal or more than 40%, and then his 6 minutes walk test should be better, and you have to take the heart team approach. And then hemodynamically, the patient should be having the V wave height that is more than 25 millimeters of Hg, and pulmonary systolic pressure should be less than 65, and it has got, there should not be any RV dysfunction. The tap size should be more than 1.4 or so, and the patient should not be suffering from any liver cirrhosis stage, Child-Pugh stage C, or serum creatinine. If it is more than 3, again it is a contraindication. If the patient is having life expectancy of less than 1 year, is also a contraindication. So what are the evidence into the TricValve is initially it is given as a compassionate grounds to reduce the symptoms in the patient. It is called a special access program which was used in the European countries basically. Almost 27 patients received this device on compassionate grounds as special access program. And in TricValve study, it is early feasibility trial which was conducted in the 9 patients in Lithuania and other countries. And also patient undergone 29 patients undergone this device deployment in Spain and Austria and etc. as a CE mark trial. So this is the first in man study which was published in 2018, which was conducted in the 25 patients. It is basically to look into the feasibility, safety and the successful procedure success. It was found to be procedure is successful and it is safe and then feasible to deploy these devices. And another important study is TricValve Euro study, which was studied in the 35 patients, where it has shown that the technical success is 97% and 6 months cardiac mortality is 0 and persistent functional improvement was noted, and also there is a quality of life improvement was noted as per the KCCQ. And also it has shown that in TricValve study and TricValve Euro study, this is the TricValve study data, when patients were initially in the class 3, class 4 symptoms, almost 90% are asymptomatic or into the NYHA class 1 or 0, only 10% remained in the class 4 symptoms. Similar findings was noted in the TricValve Euro study. This is the 6 months outcome trial. Gradually, this symptoms was reduced and NYHA function class 1 is improved to almost 80% in TricValve Euro study. And also, it has improved the 6-minute walk time as well as 6 minutes walk distance. And currently, this TricValve study is going on with the 200 patients across Europe and as well as US centers. The results are awaited. So basically, the advantages of this TricValve is it provides an effective and low-risk solution for the patients who are at high surgical risk or non-candidates for the surgery. It has got shallow learning curve, easily implanted, safe, simple, suitable for the wide variety of the patients, allows for all future tricuspid valve surgical or procedural options in future, including transcatheter edge-to-edge repair, transcatheter tricuspid valve repair, and transeptal puncture as well as pacemaker implantation. The limitations of this tricuspid valve is there may be some anatomical limitations in regard to the anchoring and sizing. There is a ventricularization of the RA pressure which may finally lead to RV failure or arrhythmias, but till now at present no such deleterious effects were observed. No randomized trials were noted till now. All these trials are only small number and used as a last resort. To conclude, it is a new, promising and less invasive procedure. It is safe and feasible, and improvement in functional status, quality of life, hemodynamics are noted in the 6 months follow-up. It requires larger studies and longer follow-up. Thank you.
Thank you, Dr. Rajaram, for your presentation.
Thank you all previous speakers for excellent presentations. Next we will move on to image-based symposium. Image and one presentation on physiological assessment. So the importance of imaging is gaining a momentum. If you see the recent ESC conference, they have presented wonderful data, robust data about the usefulness of imaging during PCI. Namely, October trial, Illuminate 4 trial, Octo-IVAS trial, and meta-analysis by Greg Stone. So these all 4 trials have shown, all 4 studies have shown, there is a consistent reduction in the mortality rate, almost 25% reduction in the mortality rate. If you see the stent thrombus, almost 50 to 60% reduction when you use the image, that image-guided PCI versus angio-guided PCI. The other reason, even at the end of the session, they also focused and they highlighted everybody should acquire the knowledge of the imaging. This is not the fact even in India. That is also, they highlighted in US and European countries to acquire the imaging knowledge I feel compared to Western countries, the momentum of imaging is more and more in India. More and more youngsters are picking up imaging. The usage of imaging, like a OCT, advanced OCT or IVAS, more and more youngsters are doing very complex PCI. That's a good thing. That's a definitely good trend. So with this brief note, I will call upon a few chairpersons, and Dr. Purohit, you can occupy the chair. And I also request the speakers to join the podium. Dr. Sudhir Koganti, Dr. Ramesh, anyhow, Sashikanth is here. Now let us move on to the first topic. This is how OCT imaging changed my decision making in simple to complex PCI by Dr. G. Ramesh, is a well-known cardiologist from Secunderabad, Yashoda. Ramesh, ready up? No image? I'm asking Ramesh, no image?
No image. Our Shravan has put those images here. In the laptop, move it and play.
You want any coffee? Coffee? Coffee चाहिए?
Yeah, there is really no image. We are accustomed to looking at a laptop and presenting. This is different. So anyway, yeah, I will not know it. We are pretty late. As Dr. Sridhar sir was saying, so definitely imaging has changed the way we practice coronary interventions, including both structural and coronary, definitely coronary interventions. OCT has got some certain niche indications. One of them is calcification. So I will just briefly show a couple of cases where we have used OCT to okay. Yeah, so this is a, you can see this, I'm not going into the history or anything. This is a calcified RCA, no stents in it. Looks like it's stented previously, but virtually it's a long diffuse disease RCA, significant calcification. So this sort of lesions, we got a couple of options. Now orbital is also there, but generally rotablation. This is a big vessel, so probably if you need to do a rotablation, probably 1.75 or a tuber. Or we have got an option of IVL, or we got an option of orbital. So how do we choose these things? The best thing is doing imaging. As we all know, in calcifications, OCT is the best choice without doubt. So we have taken a 7 French catheter, or I think 6 French only, 6 French, but AL 0.75 is what the catheter is. So initially pre-delayed with a 2.5 into 15 balloon. I have skipped the history and other parts of it. Just wants to concentrate on the OCT part of it. So initially pre-dilated the lesions. Then we took an OCT pullback. So this is, as we can see, it's a whole vessel has got 360-degree calcium. There's a calcium nodule also. I'll just briefly go through the cut sections also. So this is the OCT run after the initial pre-dilatation with the 2.5 15 balloon. Yeah, as we can see here, so there is a 360-degree calcium, but we are looking at the depth here. Suppose it's superficial calcium, obviously the only choice would have been to go for a rota, possibly orbital also. But since the depth is more, nearly 1000 microns, IVL comes into picture. So we all know that in a deep calcium, probably IVL is better than any other modality. So there is a eruptive calcium nodule also. Again, for eruptive calcium nodule, we're not very sure which is good. If you're able to do a rotablation with a good wire bias, then it's good. Otherwise, probably IVL still works for it. So significant depth of calcium, both superficial and deep, with an eruptive calcium nodule, I thought IVL would be a better choice. Since the whole vessel is significantly deceased, we have taken, now present IVL has got 120 pulses also. The new catheter has got a C3 plus has got a 120 pulses, so we can use it. Not much cost difference, few thousand rupees, but so we have used a 3.515 IVL here. So virtually exhausted all the pulses, all 120 pulses in this case. As you've seen very clearly, the guiding catheter here helps. The AL 0.75 helps here. Otherwise, not have been very easy. I will go through this. Then again dilated with a 3.515 NC. Then took an OCT pullback. This is the OCT run. We can, anyway, I'll show the cut section. We can very clearly see the cuts here. As we all know, if you need to reduce the bulk of calcium, the only modality is the rotablation. But if you're using a IVL or any other modality, generally gives cuts into the calcium, but does not reduce the calcium bulk. But in this patient, probably this would have been the ideal one. We can see calcium cracks into it, significant calcium cracks, which we can notice it. This is the previous comparison between the pre and post. Very clearly, we can see the calcium cracks here. So that's the beauty of OCT. You can assess it properly. In a proximal area, we found that there was an area which was not expanded in the OCT. So again, we took an OP and NC to dilate it. So went up to nearly 30 or 35 with an OP and NC. Here we took a 315. The vessel size is 3.5. Generally, if you're pre-dilating, I generally try to take 0.5 less, not the exact this thing. So we have taken a 315. Then, so this taken a 3.538 stent for the distal RCA and 3.538 for the proximal RCA. And post dilation done with a 3.515. So this is the OCT pullback. It's a fairly well expanded stent, good apposition, and area is pretty good. So in this OCT has guided us to choose the appropriate strategy of IVL. Many times we do take, whenever no catheter goes, either an IVS or OCT goes, we generally try to go for a notablation. This is the final result. Small case here again. This is a inferior wall MI. There is a moderate sort of stenosis in the mid RCA. Again, in these cases, OCT does help. This is around 50-55-year-old male, not a very young male. Probably young male would have left him on heparin. This is a more 55-year-old male. So we thought, let's do an OCT and see what is there. So this is the OCT run. I think I'll skip it because of lack of time. Let me show you this thing. So this is what we find. This is the red thrombus there. This is a plaque rupture. Generally, a couple of conditions where we need to stent it is when there's a plaque rupture or there's an eruptive calcium nodule. These are two conditions in ACS where we generally need to stent it. So plaque erosion, probably we can avoid stenting it. These are the macrophages. We can clearly see the macrophages there. There's a plaque rupture, there's a red thrombus, recanalase thrombus also is there. So since this is a case where there is a plaque rupture, we thought stenting would be good. So this is a 3.548 stent. Post dilatation done. So pure plaque erosion, probably we could have left it off with putting him on heparin and probably waiting. So post stenting and OCT run. This is the pre and the post. It's a fairly good result. Last case, you know the definition of SCAD, there are three types. One has got multiple radiolucent lumens in the artery. The other one has got long diffuse disease. If a diffuse disease is not extending up to the tip of the artery, then it's type 2A. If it's extending up to the tip of the artery, then it's type 2B. And if it's a focal tubular stenosis, it's type 3. This OCT is classical, this thing. So we don't need to chase all SCADs here. Here we did a patient had presented with ACS. We did a stress thallium. The stress thallium was positive. Antral MI. So we did an OCT run in this case. I will show you. The classic definition is the lotus root appearance. We can see there. So the classic lotus root appearance of SCAD. This is what the definition of SCAD OCT run says. They say this is a classic. You see the central circle followed by the peripheral circle. It's classic lotus root here. Thallium was positive for ischemia here. OCT was showing the same thing. Stented the patient. Post stent, good result. Thank you. Just wanted to show some illustrative cases. Did not want to bombard too much stuff. Thank you.
Yeah, Ramesh, wonderful cases. But I differ in last case. I need the opinion of Sudhir as well as the Purohit. The lotus appearance, lotus root appearance or spider web appearance or that Swiss cheese appearance is a classical of recanalized thrombus. It is not a appearance of the SCAD. SCAD shows true lumen, false lumen, and through this. This is only recanalized thrombus. Classic lotus root. There is a lotus registry.
Lotus root is, they say it's
This
for
is
SCAD.
no, not SCAD. It's only recanalized thrombus. The lotus registry, they have analyzed 29 patients. In the 29 patients, they did though angiographically intermediate lesions, borderline lesions, they did FFR also. The angiographically, it may not be very significant, mild to moderate, but majority are symptomatic. Yeah. When they did FFR, all these lesions were positive. The lotus or switches or the spider web appearance is mainly seen in recanalized thrombus, not in
But in type 2 SCAD, they say lotus root is the classic appearance. Sir.
No,
I will show you once this is done.
Not shown. I am writing a book on OCT. I reviewed everything. Yeah.
Usually for SCAD, we don't stent unless it's showing very clear.
This was showing
inducible ischemia, it's positive, and you could cross into the true lumen, and
that's risky
probably
sometimes.
medical management would be the first option for me.
I think in the first case, I think probably if the OCT was not taken, then probably the preferred modality would have been a rotablator, I think. But because there was a nodule, I think that maybe have guided you to take a balloon, right? IVL balloon. Correct. I think it was an excellent demonstration how a OCT really helps us in deciding, because many a times we just go by angiographically, and that's the reason why we have an underexpanded stent, and then subsequently that leads to restenosis and all these things. So if you have a complex scenario, it is always better to see and then decide your modality, what modality you are going to use for doing the angioplasty.
Thank you.
Wonderful speaking images. These images themselves, they can tell volumes of knowledge. And a nice illustration of every case, even you showed the plaque modification, the fracture of the calcium, everything. That is the evidence of plaque modification. But a wonderful presentation. Thank you. Thank you, Ramesh.
So that's the beauty of presentation, actually, of this OCT, wherein you see the thrombus, the plaque erosion, plaque rupture, calcification, a SCAD, and you see the vessel as if you're seeing it from inside. It's a beautiful presentation. Thank you. I think we'll move on to the next presentation. I think Dr. Sudhir Koganti is here with us. How to interpret Illumin 4 trial in routine clinical practice. Dr. Sudhir Koganti, please.
Yeah, connected.
Yeah, it's coming there. What is this? Yeah, just close it. Yeah, great. Thank you so much to Dr. SridharKasturi and the organizers for giving me this opportunity. Just before I start the talk, just a show of hands, including the panel, just a hypothetical question. If I were to tell you in middle AD or proximal AD there's 80% stenosis angiographically, how many of you would want a PCI with OCT or IVUS guidance, imaging guidance? How many without? Great, I don't think we need this talk. Right, so with that, we'll just go through this really phenomenal trial which was presented at ESC in August this year. One of the many imaging studies which was presented. This one was led by Ziad Ali. The background of this study is, PCI is mostly done by angiography alone. We all know the take-up rates in most of the countries due to with the availability of the registries. I think Japan almost 85-90% they do PCI with imaging, but rest of the Western countries I think is less. India, I think they're taking up more, but we don't have the data to see what percentage actually, is done with the help of imaging. So mostly still angiography, apart from few select countries. And yeah, as you all know, OCT is a high-resolution intravascular imaging which uses infrared rays and gives you really crystal clear images. And Illumin 3, and in fact, the previous studies, Illumin 1, and there was even a registry data which our group published in JAC prior to Illumin 3, clearly showed OCT or even imaging for that matter, IVUS definitely has got randomized data. The outcomes are better when you do PCI with imaging. Illumin 3 actually showed greater stent expansion and reduced major malapposition and major dissections, but it wasn't a study to look at hard endpoints. So that is where the Illumin 4 comes. I think any technique or technology which you want to implement into day-to-day practice in cardiology, particularly interventional cardiology, you need a good randomized trial showing benefit in hard endpoints. And that is the basis for the Illumin 4. And it's a 1:1 randomized study with a primary imaging endpoint as an acute minimum stent area and a primary clinical endpoint as a target vessel failure at 2 years. Now, just going back to why we are harping on the stent area, minimum stent area. So the studies again have shown previously, particularly with IVUS and also the registry data, the bigger stent area at the end of the PCI meant better outcomes. And in Illumin 3, the MSA that was achieved at the end with OCT was almost like 6.1, 6.2. With angiography, it was also high with angiography, but there was about a 0.4 mm difference, which made the basis in power calculation for the Illumin 4 study. And the qualifying high-risk criteria are patients with diabetes, STEMI, more than 24 hours onset, long lesion lengths, calcific lesions, bifurcations, and CTOs, all sorts of your pretty much day-to-day practice, kind of an all-comer population. And this is the primary, these are the endpoints. Post-PCI MSA assessed by OCT, and it is a powered endpoint. And like I said, the difference was 0.4 millimeter square between angiography and OCT. And the primary clinical endpoint is a TVF during 2-year follow-up to show superior of OCT to angiography. Again, it's powered. And there are a couple of non-powered endpoints, primarily stent thrombosis. So randomization follow-up was pretty standard and pretty strict too. In fact, you had to show the MSA difference at various stages of the study to show if you could continue or not in terms of recruitment. Baseline characteristics between OCT and angiography are similar. And qualifying characteristics are also similar. No particular difference in between both the arms. And in terms of angiographic characteristics, the arteries which were done, thrombus calcification, reference vessel diameters, MLDs, they're all evenly matched. Lesion length seems to be slightly longer in OCT arm. And the procedural characteristics, there are a few differences here. The stent length, maximal stent diameter, and post-dilatation number of balloons that were used for to achieve a good stent expansion were all slightly bigger, longer in OCT arm. The procedure duration is obviously longer in OCT arm because you're going to do multiple runs to assess the result, the PCR result. And the procedure, the fluoroscopy duration is also higher, like was the radiation, and also the contrast volume, but this did not necessarily lead to any meaningful harm in terms of contrast-induced nephropathy. And coming to the results, this is a primary imaging endpoint. When you look at final post-PCI MSA by OCT, it's 5.72 plus minus 2.04. There's a clear difference in terms of stent expansion between OCT and angiography, and this is statistically significant too. And stent expansion endpoints are again minimum stent expansion is higher in OCT, mean stent expansion is larger in OCT, and the kind of stent expansion which you see with acceptable across the longitudinal pullback in terms of 90% is also good with OCT. When you look at other findings such as dissections, everything had clear definition. Dissections, tissue protrusions, they're all in terms of lesser in the OCT arm. And the angiographic, when you look at angiographic complications, these are the core lab adjudicated complications. No significant difference. Actually, it's safe pretty much. Procedure-related thrombotic events are slightly higher across both arms, but more so in angiographic arm. So when you look at primary clinical endpoint, which is TVF, defined by cardiac death, target lesion revascularization, or ischemia-driven target lesion revascularization, there was no difference, surprisingly no difference. Though we achieved really large stent areas in the OCT arm, there wasn't much difference in TVF in terms of outcomes at the end of 2 years. So when you look at individual components, cardiac death, I mean, numerically they're all less in the OCT arm, but statistically none of these were significant. Cardiac death is P is 0.17. Target vessel MI, again, statistically not significant, though, like I said, numerically it's lesser in OCT arm. And the ischemia-driven target revascularization is pretty much even-Stevens, actually, across both the arms. However, when you look at the stent thrombosis, with the caveat that this wasn't powered for, it's definitely lesser in the OCT arm over a period of 2 years. And across both the arms, there were about 23 stent thrombosis events, of which death or MI occurred in 22 patients. So in other words, stent thrombosis is not something which any of us would accept or should accept. So other endpoints in terms of 2-year clinical outcomes, all-cause mortality, all MI, all revascularization are all similar, not much difference really. Ziad Ali, when he presented the study, alluded to impact of the COVID in terms of the on the results actually. So pre-COVID, when they recruited about 400 odd patients, there was clear difference in terms of outcomes. So this is TVF, where there's clear difference, 7.2% in OCT arm and 10.1% in the angiographic arm. But that did not translate into the full results when the full recruitment was completed. So one possible explanation is during COVID, particularly in the Western world, there were all online appointments, no physical appointments. So, and also people probably were worried to go to hospitals to catch, that they were worried they might catch COVID and things. So in terms of, because like I said, this is primarily driven by, this endpoint is primarily driven by ischemia-driven target lesion revascularization, that maybe they were symptomatic, but they were tending to kind of ignore and stay at home. Whereas, I mean, it should equally affect the OCT arm as well, but by using OCT, maybe we achieved better stent areas, less major dissections because you had the chance to correct it, whereas the angiographic arm were blinded, no chance to correct it, so that they probably had better, lesser events, in other words. So that's one possibility. And actually, when you look through the supplementary index of the Illumin 4 trial, this is striking, but I think the investigators really stuck to their power endpoints and did not allude to all this to glorify the findings. When you see here, when they tried to break down into MSA at 5.2 millimeters square, there's a clear difference in TVF at 2 years. So if you could achieve MLA of 5.2, I think the events are going to be less. And I think this is the relevant bit. So the title of the talk is actually, how do we put this into our day-to-day practice? I think we're already achieving this 5.2. I think our interventional practice has got so much better over the years that we no longer accept the direct stenting. I think we're good in lesion preparation. We choose the right stent, and we always meticulously post-dilate. All the good interventional cardiologists, they never accept a substandard result. I think, which is actually, I think we're already achieving this MSA in our day-to-day practice, which is actually probably helping in terms of reducing the hard endpoints. And then there was also this October trial, just a slide on it, clearly shown when OCT was used in complex subset of populations like bifurcation lesions, it trumps the angiographic guided PCI. There's a big difference in terms of MACE over 2 years. So in conclusion, OCT guidance resulted in larger MSA than angiographic guidance with greater stent expansion. It led to fewer major dissections, major malapposition, major tissue protrusion, and untreated focal reference segment disease. And it also reduced angiographic complications. The 2-year rates of TAVR were not statistically different between both the arms, and OCT-guided PCI significantly reduced stent thrombosis, and there were trends for fewer cardiac deaths and MI with OCT guidance consistent with prior intravascular imaging studies. And COVID may have had some role in terms of TVF rates. Thank you so much.
Thank you, Dr. Sudhir. That was a wonderful presentation. A good summary of OCT in the latest trial, Element 4. I had two doubts in this. Did we use longer stents? Was it significant, the use of the stent length?
No, slightly. I think the lengths were longer, but statistically it wasn't significant between both arms.
Yeah. Got you. And do you do saline OCTs nowadays, or you just do a contrast?
No, still sticking to contrast OCTs. But I think there is a way to do it. I think you need like a guideliner for a better flush, but you can do it with saline. But usually we're doing with contrast. RCA. Yeah.
RCA, at least I am doing 50% of the time saline OCT for RCS.
But I think it's shown in the study that even the higher dose of contrast didn't really lead to any contrast.
But endpoint is if you are getting good images with saline OCT, you can manage. It's like
I mean, provided you choose a patient whose GFR is good. Otherwise,
If GFR is less, better go for NIVAS in that way. I think no point in going for OCT.
Yeah, because now the SDIVS is so beautiful. The images are very high resolution images compared to earlier generation.
Correct.
Now if you have HDIVS, particularly when the CKD is there, very significant, very low GFR is there, IVS is a very safe set. Otherwise, the images of the OCT, unparalleled, frankly. It's like Eastman, comparing the black and white versus Eastman color picture.
So if you have the chroma flow, then with IVS you can even do the tissue characterization.
Recently we were until recently we were dependent on only IVS-based data, like IVS XPL or any other study. But now the data about the OCT also more favorable because all 4 trials showed the consistent results.
Absolutely.
But in this one, there is a one contradictory result. I think subset analysis, if you see, in diabetic subset, diabetic treatment, results were not that great. How do you see that one?
Well,
maybe observational error.
And also, they're not powered, right? So it gets difficult when you go down to the subset. So I think, sir, my observation is our OCT, I think this trial came too late. I think our practice is already so good. Yeah.
Thank you. Wonderful presentation.
Thanks, sir.
Thank you, Dr. Sudhir. I invite last speaker, Dr. Pranay, who will be speaking on orbital atherectomy and plaque modification. It's a new technology, newer technology which we are adapting more and more nowadays when we have some specific situations of significant calcium and needing a plaque modification. So plaque modification by orbital atherectomy, Dr. Pranay.
Good evening to you all. So I'll be discussing about a case of plaque modification involving 2 vessels, RC and LAD. So it's a 67-year-old female who is a diabetic hypertensive, presented with complaints of chest pain for past 1 month and dyspnea on exertion for 15 days. ECG was fairly normal, echo was normal function, TMT was positive for inducible ischemia. Her hemoglobin was 9.6, troponin were not elevated, no CPK MBK elevation. So diagnosis of chronic stable angina. So we took her for a coronary angiogram. So her angiogram showed there is a proximal LAD lesion which is 90% and there is a thick slab of calcium over there. So there is a thick slab of calcium over here which we can see in both the views, and there is a tight stenosis of the LAD. And for the right coronary artery there was a tight stenosis distally, mid there was some calcification speck. So what we decided is either go for CABG or do a multivessel PCI with plaque modification using an imaging. So what patient decided is to go for stenting. So we did right coronary because it was very tight lesion. So we wired the RCA first with our workhorse wire, and then we acquired an image. So the OCT image shows that there is a thick fibrotic lesions from the distal portion of the RCA till the proximal part, and there is some calcification, but the calcium is not that dense and not more than 90 degrees. So what we thought is we modify this with cutting balloon. So we tried to pass the balloon. First it was very difficult, so we took a guide extension and then took this 2.5 into 15 angiosculpt balloon, and then got a good cut, dissection in the arteries, and then we deployed 2 stents, that 348 and 3.548. So, and then we post dilated with 315 and 3.5, and then took an OCT, and our OCT image was very beautiful and showed that there is a good opposition of the stent, no under expansion, good areas were achieved. After completing the RCA shoot, we went on to the left system. So left was engaged with 37 guide, and then we acquired an OCT image. The OCT image here shows that there is a thick calcification from the proximal to the mid part of the LAD, and the thickness of the calcium is too dense, and it is all across more than 270 degrees calcification, which we can see, and the distal landing zone in the mid part is good. So what we decided here is we modify this with a plaque modification therapy, and we chose orbital atherectomy. So now orbital atherectomy is new to our lab, and the orbital atherectomy usually we do by slow runs first at 80K and then 120K. So this is the crown which we can see here. We parked it in the LMCA, and then we are shaving the calcification slowly at the 80K speed. Now to explain everybody what is orbital atherectomy, it has a nose cone. There is a diamond mounted roll here which wobbles around the artery in a circumferential arc. Slower the speed, more is in this diagram we can see that the slower the speed of the motion of our burr, more the area we can shave. As we move faster, the areas of shaving is less, and we tend to miss some part of the calcification and the plaque. So after shaving this, we acquired an image. So here we can see there are beautiful cuts in the lesion, and we have shaved the areas more as compared to the previous one. So to explain everybody what is orbital atherectomy and how does it work is, so this is the orbital atherectomy burr which has these diamond particles mounted on that, and this is the handy workstation which has the knob over here through which we can move it forward and backwards. Here are the 2 knobs which gives us the speed at 80K and 120K, and we also can change it to a glide mode, and here is the brake paddle. So how does this atherectomy basically works? It basically works with the physics of centrifugal force, that is mv square upon r. So more the mass, more the velocity, more the areas we shave. As we increase the radius of that, as we increase the speed, less will be the centrifugal force, though more we cannot achieve that. And the burr size available is 1.25 only, and it achieves good areas. So once we cut it, we dilate it with the NC balloon, and we deployed a 2.75 to 38 Zions Alpine stent, and then we post dilated with 315 NC direct. And final OCT images
Showed a good opposition of the stent with good expansion, distal landing is good, proximal landing is good, no complication, and the areas of the stents are very good. So this is the final result what we acquired after the OCT. So we have different modalities for plaque modification. The below image is the rotablation. Newer to our addition is orbital atherectomy, and quickly we'll be adding laser atherectomy to our lab. Thank you.
Thank you. Thank you so much, Dr. Pranay. I think this is a new technology which we are using now more and more in such situations, and it's showing good results. Yeah. Yeah.
I thank all chairpersons and speakers for wonderful. And with this note, we have closed this session, and we will give half an hour break, and followed by we have a cultural night, and during that, and I think we are expecting more and more guests. Now we have an award session. We are going to felicitate many doctors who achieved phenomenally in our field. So please don't go out and stay with us and enjoy the event. Thank you, Anadal. We will give a 15 minutes to half an hour break, and snacks will be served. You can have a cup of coffee or tea and snacks and refresh yourself and sit here. Just to relax and enjoy the program. Thank you, one and all.